All we need is to know whether he is all right. So at least in a study, we should take pains to get it done, so that we don't come up with a figure of 34%.
So, good morning. We move on to the study. This was routine clinical practice. It's not a clinical trial. We were just gradually learning, and this is the ground reality. Our actual loss to follow-up in PGI is 60% outside the clinical trial. It's 25 to 30% in clinical trials, and we publish in international journals whatever we've done, taking the best and the worst case scenario to tell the truth of the matter.
I think we should take pains in cancer centers to reduce it. At the cancer center in Chennai, Adayar, we have an overall follow-up close to 80%, and in certain regions like breast, we are touching close to 90% follow-up. And this has been presented in the National Registry Program. I think all cancer centers should take efforts to get a good follow-up. Only then the Indian scientific data will carry more weight. Thank you, Dr. Shalin Kumar.
Now we move on to the second topic, the scope for radical chemoradiotherapy in carcinoma of the esophagus. Today's speaker is Dr. Najib Moideen. He is the senior consultant radiation oncologist and Health Policy Council Chair, Illinois, US. May I invite Dr. Moideen.
Thank you to the panel, and good morning, delegates. And thank you to Dr. Vijayanand Reddy and Dr. Tripuruneni for the invitation to speak here today. Dr. Shalin Kumar has set a very high standard for this talk, because he has said the standard of care is neoadjuvant chemotherapy followed by surgery. So here I am trying to say that definitive chemoradiation should also be an option. So what we will try to cover in this, we will look at the impact of chemoradiation, and then we'll discuss some strategies that have been employed to improve outcomes, and then we'll end up with some tips on treatment planning and advanced technology and so on. So, what dictates therapy? And Dr. Shalin Kumar clearly stated the local stage and the regional stage clearly dictate therapy. The reality is the vast majority of these patients present with locally advanced disease, sometimes unresectable disease. And the staging system for esophageal cancer has been changing, and so much so that if you're in the clinic and trying to stage these patients, you need to have the staging book open in front of you, because you now have tumors that may extend into the cardia up to 5 centimeters that are still considered as esophageal cancer. So I will try to focus on thoracic squamous cell esophageal cancer, which is the more common type in this country. Location is important, histology is important, but most importantly, mortality, 12% fistula rate, and so on. And that, despite the improvements in local control, the overall survivals were not really any different from the combined chemoradiation studies. So, just as Dr. Shalin Kumar alluded to, can you use surgery to improve the therapeutic outcome? And these are the two studies he showed. The German study, T3, T4, N1, which correlates with a pathologic response. But this is data that is still emerging radiation boost, because you don't want to have that big a gap in your protocol. So I think we have to look, still await. I think it's still under study, under protocol, and I don't think we are ready to accept PET as a way to screen patients who would benefit from surgery versus continuing radiation. Can you then intensify the chemo and intensify the radiation and improve the outcomes? And I put the title here, a cautionary note, because the Japanese tried to do it. they added 3 drugs, docetaxel, cisplatin, and 5-FU, and they increased the radiation to 61.2 gray. And they ended up with grade 3 esophageal toxicities in around 42% of their patients. And if you look at the late toxicities, you can see pericardial effusion, pleural effusion 81%, esophageal related complications including stenosis and fistula, so much so that they had to reduce the dose of radiation down to 50.4 gray. So again, treatment intensification should only be on protocol. And at that dose, however, they had a complete clinical response of 60%. And I forgot to say one thing about the study. These were all T4 patients, very advanced patients, or M1 patients. So these were not the early stage, but in that group of patients with this intensified treatment and 50.4 gray, they did get an excellent complete clinical response. So again, about dose intensification, here's the SCOPE study. Cetuximab works very well in squamous cell cancers. It works well in head and neck cancer. So why not add it to esophageal cancer? Cisplatin, capecitabine, which is a good substitute for 5-FU, with cetuximab versus cisplatin, capecitabine alone. The radiation dose was 50 gray in 25 fractions, 258 patients randomized, and that's what I want to show you here. 85% of these patients were PET staged. 77 was stage 3, 72% were squamous cell cancers. These were generally older patients. The median age was also higher, 66. Okay? What happened? The full protocol dose of radiation in the cetuximab arm could only be given to 78% of patients. So an essential component of the treatment could not be given to nearly 22% of patients. In fact, 19% received no radiation. And what happened as a result of that? That was primarily because of non-hematologic toxicities. And what happened as a result? The median survival was superior in the chemoradiation arm, and so was the 2-year survival. The median survival was 25 months. The 2-year survival was 56% in the chemoradiation without cetuximab arm. Now, this is very impressive, but think back to RTOG 8501. This was what, 14 months, and this was miserable. However, these are PET-staged patients. So when you look at the literature, it's important to look at how these patients were staged, because patient selection may drive the results. So that's a very important part of the message that I would like to send to you. But nevertheless, what this shows is just simply intensifying the treatment has to be done on protocol. Okay. Let me end with a few thoughts on treatment planning and techniques. Now, we now are in the era of 3D conformal planning. We use a lot of imaging tools, including endoscopic ultrasound and CT, and even PET to define the gross target volume, the gross lymph node volume, etc. The CTV has to be, there is the clinical target volume, expansion of the GTV by 4 cm superiorly and inferiorly. It has to follow the natural contours of the esophagus and the GE junction and the cardia. And you have to cover the nodal stations. For example, lower esophagus GE junction, you would cover the celiac plexus. Mid-esophagus, you would cover the paramediastinal nodes. Cervical esophagus, which is probably more a radiation, chemoradiation disease than surgery, we are not even talking about that, you probably cover the supraclavicle and the cervical nodes. So that's important target volume information that you need to know. And then you need to know what causes our toxicities. You need to be sure about your V20 doses to the lung, volume of lung exposed to 20 gray. And there are many formulae and stuff like that. This is one of them. Try to restrict your V20 less than 30%. But look here, I've also put V5, smaller doses. Try to restrict that to less than 50% or 60%. Mean lung dose of 20 gray. And also for cardiovascular disease, V40 gray, volume of the heart exposed to 40 gray to less than 30%. Try to exclude the left ventricle completely. So what about advanced technologies, IMRT? Well, a lot of studies, but again, most of them are dosimetric endpoints, improving cardiac doses, improving lung doses, improving V20. One study from India increased V20 and V30 with increased radiation pneumonitis. This is a study from MD Anderson, published in the Red Journal, 433 patients, half of them got IMRT, and they did a propensity analysis to make sure they balance out the variables. And what they found was there were fewer cardiac deaths and improved overall survival and local control in the IMRT arm. So that's what they are doing. However, it's not the standard of care internationally or nationally even. Why is it important to be careful about all these technologies? Here is a dose display of 3D giving 40 gray, and with IMRT you see really nicely conformal doses. What happens to the low dose 6 gray? It's played all over the lung. And we do know now that if this patient is to go for preoperative chemoradiation followed by surgery, the postoperative pulmonary complications are going to be higher. So you just cannot blindly adopt new technology without understanding all the issues that go around when you use lower doses to the lung volume. And lung tolerances may even be lower if you're using chemotherapy, maybe 18 gray, V18 may be what you should be looking at. But this is why you have to be careful in your treatment planning. And nevertheless, there's going to be modern technology that we use. There's studies that show that PET may be a valuable tool in defining GTV. PET may cause decreased GTV compared to your CT. However, you cannot just simply fuse these studies and just contour the blob that you see on your PET scan. You have to analyze this, study this, use that as a tool, but don't just blindly believe that. 4D CT and IGRT are also going to are used when IMRT is used. In the interest of time, I want to spend a minute on modern brachytherapy planning. When we did our residency years ago, brachytherapy was sticking a Riles tube and dropping some sources down and thinking that you gave the dose. But brachytherapy is a multidisciplinary specialty. You have to have your endoscopist in there directing where the esophageal bougie goes. You have to select the esophageal bougie thus that there is very little air gap between the mucosa and the catheter. And then you have to be sure that your active source length transcends the lesion, and you have to be sure that you know where you're prescribing. Are you prescribing 5 millimeters from the surface of the applicator, like the Japanese do? Are you using the bracket ABS formula from the central axis of the source, prescribe at 1 cm? You have to be consistent in what you do to avoid complications. Because think of it, when you place this large bougie in the esophagus, the thickness of the wall of the esophagus is about 2.5 millimeters. So if you want to prevent toxicities and complications, this is a very carefully done procedure. So I will briefly touch on those.
And as we know, the treatment of any cancer is multimodal in the present day. That gastric cancer is not an exception to that particular thing. So radiation, surgical and medical oncology plays an important role in the cure of these patients, but still surgery is the pivotal treatment in curative intent treatment of gastric cancers. I'll be delving on the extent of surgery which is considered as optimal for these cancer patients and which is ideal and which is say that diagnostic laparoscopy before we go ahead with a definitive resection. because as we said, in India we do not really notice it around 1/3 unresectability, but we do have around 10% unresectability because of peritoneal metastatic disease or ascites, which is positive for malignancy. As you can see from the MS cases database, an R0 resection has much better overall result compared to any R plus resection, whether microscopic or macroscopic. No amount of adjuvant therapy can really take over the responsibility of curing the patient in here. R0 resection is what we should be aiming at and should be able to achieve that one. Now, how do you define an oncologically sound resection? Now, the type of resection that we do may vary from location of the tumor and the size of the tumor. But what we are trying to achieve is at least a 5 centimeter margin, both distally and proximally. Now, the 5 centimeters is supposed to be adequate in the intestinal type, which is the commonest type of malignancy in the stomach. And in the diffuse type, which is a little more aggressive and which has got a higher incidence of mucosal spread and lymphatic spread along the stomach wall itself, the minimum accepted and which is proposed is around 8 centimeters. But typically, we aim at around 5 to 6 centimeters margin for all the malignancies, because most of the times we are not very sure whether it's an intestinal type or a diffuse type based on the morphological appearance alone. The minimum accepted for any surgical procedure in the stomach is actually 2 to 3 centimeters. So when you have a frozen facility, probably when you have the need to avoid a total gastrectomy, probably you can do a resection with around 3 centimeters margin, but otherwise the minimum that we should be aiming at is around 5 to 6 centimeters margin. Whenever there is a suspicious adhesion, whenever there is a suspicious invasion into the local tissues or local organs, we should aim at to go for an oblong resection. And unfortunately, these resections are the reason for increased morbidity and mortality. So these patients are to be chosen very, very cautiously. The importance of low morbidity cannot be highlighted here. Now, depending on the type of resection that are being done, there have been quite a few studies. Now, some of the studies which have looked at the importance of the location of the tumor and the type of surgery being planned, we will be discussing about those things. Now, when we have a disease which is involving the body and the proximal stomach, we have no choice but go ahead with a radical total gastrectomy. But those patients who have a disease in the distal third, which is a very common situation in this country, I would say in our country, more than 70% of the cancers in the stomach are distal third and distal half of the stomach. So there have been few studies which have looked at the possibility of increasing the overall outcomes by increasing the extent of primary resection. Now they have looked at doing a total gastrectomy versus distal radical or subtotal gastrectomy for the distal tumors. Unfortunately, what they have realized is, in spite of having a huge number of patients in the French and the Italian studies, they have not found any improvement in the overall survival. And fortunately, they did not have much of difference in the post-op morbidity and mortality, but they have found no improvement in the overall survival and the disease-free survival, which proves the point that we need not always be very radical in terms of doing a total gastrectomy in distal gastric tumors. So it goes to say that a distal radical gastrectomy or a subtotal gastrectomy up to the incisura is considered oncologically adequate for the treatment of early malignancies of intestinal and diffuse types in patients with distal third malignancies. In all the other cases where you have involvement of the middle third of the body of the stomach and cardia, a total gastrectomy should be performed. As I said, we should aim at a margin of around 5 to 6 centimeters of negative margin. Now, we are seeing more and more of proximal cancers. Definitely, it is increasing slowly in this country also. And those patients who have a tumor closer to the GE junction, like in the type 2 and type 3 sieverts, they should be going for extension of gastrectomy with the transhiatal resection of the esophagus also. In those patients who have much more extension into the lower third, we usually plan an esophageal gastrectomy with a colonic pull-up. An example of subtotal gastrectomy, a total gastrectomy with reconstruction. And very rarely done procedure for us in this country is a proximal gastric resection, proximal gastrectomy with a vagal preservation. We hardly ever get to do these cases in this country. Most of the cases that come to us are basically patients with involvement of the lower third of the esophagus, where we end up doing gastroesophagectomy rather than doing a proximal gastrectomy. Now, one point which has been proven beyond doubt is the technique of reconstruction has absolutely no impact on the overall survival or the disease-free survival of these patients. So the type of reconstruction that the surgeon plans, it may be a Billroth 1, Billroth 2 or a Ruo Y, with or without a pouch, with or without usage of staplers, has got absolutely no bearing on the overall outcomes of the oncologic outcomes of these patients. That's the surgeon's choice, and he can exercise it as he wills. Now, going ahead with the lymphatic clearances, there has been a long and tedious debate about whether to go ahead with D1 or D2 resections. And there has been quite some amount of background for this particular thing. The controversy arose because there has been a wealth of retrospective data from the Japanese which said D2 lymphadenectomies can be done with low morbidity, low mortality, with far better oncologic outcomes than D1 resections. And the Japanese group has identified 16 lymph node stations for the stomach, and depending on the lymph node stations, they have defined the N1 nodes as 1 to 6, which are basically the perigastric nodes, N2 nodes as nodes along the named vessels of the stomach, N3 nodes are in the hepatoduodenal ligament, retropancreatic, and nodes at the roots of the mesentery, N4 nodes as nodes along the middle colic veins and pararetic nodes. So this, by definition, D1 dissection basically is removal of nodes along the perigastric walls, basically removal of the stomach with perigastric nodes only. But D2 lymphadenectomy involves removal of stations 7 to 11. It also includes a distal pancreatectomy and splenectomy in its classical form. And it also includes the removal of the greater and lesser omentum, superior leaf of the mesocolon and the pancreatic capsule. So to study the impact of this extent of lymphadenectomy, there have been quite a few prospective randomized trials. The most famous of them and most discussed ones are the Dutch trial and the British MRC trial. Let us look at these trials. The Dutch trial was a multi-center trial with 80 Dutch hospitals involved in the study. 711 patients studied, and what they found was a much higher rate of complications with D2 lymphadenectomy, 43% versus 25%, a much higher number of post-operative deaths, 10% versus 4%. To be frank, 10% mortality basically means 1 in 10 patients dying of this particular surgery, which is very, very high and which is absolutely unacceptable in the modern day world. And they also had a higher hospital stay for D2 lymphadenectomy patients. The similar story with the British MRC's trial done by the Cusherier group. They also had a higher rate of complications with D2, higher rate of post-operative deaths with D2, though their hospital stay was similar. What was the counterpoint against these studies? The importance is gastric cancer results are much better when they are done in a center which has got high volume of this disease. The Japanese studies and the Korean studies which are coming are basically done in places where they have a huge volume of patients being studied. So these studies, they had a problem with this particular thing. They were all, if you look at it, 80 centers doing 711 cases, basically means hardly any institution has contributed more than 10 number. It's a median number. And if you look at it, some of the surgeons might have contributed only hardly 1 or 2 cases there. So this particular thing might be the reason why they had higher morbidity and mortality. Apart from that particular thing, the Western patients are having higher BMI, their patient population is different, probably the disease itself is different. The one thing that was noticed is that the technique of D2 lymphadenectomy, which involves the splenectomy and left pancreatectomy, is supposed to be the reason, one of the reasons why they have a higher morbidity and mortality. The further studies which have come later on were non-randomized, but they have got adequate power to kind of say that there is some amount of impact with the D2 lymphadenectomy. These are the studies which have looked at the modified D2 lymphadenectomy. The German study which said there is no increased mortality with modification of the D2 technique, where instead of doing the pancreatectomy, they did the pancreas preserving and spleen preserving D2 lymphadenectomies. They also noted that over a period of time, they do look at an improvement in the survival of stage 2 and 3A patients. Similarly, if you look back at the Dutch study, they also, when they did the reanalysis 11 years of the study, they found that there is a trend towards significant survival advantage from spleen and pancreas preserving D2 lymphadenectomies. And when they had seen the long-term results of this Dutch study, at 15 years, they found that the tumor-associated death rate, or basically the mortality because of the tumor, is much better with the D2 lymphadenectomies compared to the D1 lymphadenectomies. So we can really conclude that by preservation of the spleen and pancreas, we can perform D2 lymphadenectomies safely with no extra morbidity and mortality, and this does add to the overall survival of these patients. Not only just the D1 or D2 lymphadenectomy that we are talking about, there is also an impact of the number of nodes in the final specimen which affects the overall survival. Again, we are looking at the MSKCC data which looks at the number of nodes removed in these patients. Those patients who had N1 disease on the TNM classification, when they had more than 15 nodes removed, disease, the extent of the disease on the imaging and endoscopic techniques. But the aim should be to be able to do a D2 lymphadenectomy safely, to be able to do a gastric resection safely, to be able to preserve as much stomach as is possible with good margins on the disease site, and at the same time be able to do the procedure without having to resort to a splenectomy or a distal pancreatectomy. Now, this has been the story about open surgical procedure. In the recent times, we are being exposed to more and more minimally invasive surgical techniques. Laparoscopic surgery has taken over in many situations, and it has come into oncology in a big way in the recent times. And thanks to the advanced and surgeon-friendly ergonomics of robotic surgery, it is also coming into a big way in malignant tumor management. Now, to address this particular thing, there has been a large retrospective data from the Korean group from Kim et al., where they have looked upon their data over the last 7 years, involving 3,000 patients, which is a very huge number coming from a single country. And it also points towards their centers which have got a huge number of volumes. This data looked at only 10 surgeons. Average contribution from each surgeon being around 300 patients over 7 years, which is a very, very large volume. Now, these people, they have looked at the overall survivals, disease-specific survivals, and recurrence-free survivals. So they found no difference in surgical morbidity, mortality, and post-operative recovery when they have resorted to laparoscopic gastrectomy compared to an open gastrectomy. They had 1,500 patients in each group. They had looked at case-matched study, but it is not like randomized study. Now, this particular thing has become the data which has driven the next level of investigation, which is a class 1 study, which is a randomized control trial, which is ongoing. But they also noticed in a subgroup analysis that there is a trend towards better survival in early stage cancers when they do a laparoscopic resection, probably to do with increased nodal yield. Now, this is a small note about the enigmatic entity called early gastric cancer. We keep on hearing about early gastric cancer, we hardly ever get to see that one. I'm yet to see one early gastric cancer which has been managed with minimally invasive techniques so far. Now, this is the description of early gastric cancer described by the Japanese, defined by the Japanese, and discussed in many forums by the Japanese, which is a disease confined to the mucosa and submucosa, irrespective of the size of the lesion and irrespective of the lymph nodal status. Several different classifications have typed them, and the commonest being the type 2C. They have achieved excellent local control and overall survivals in these patients. Now, what they find is 99% of these patients will be surviving 5 years if they have an intramucosal carcinoma, 96% if they have a submucosal carcinoma. Lymph nodal metastases were noticed in 3% with intramucosal and 20% with submucosal. Those patients who had nodal disease had undergone a laparoscopic or an open lymphadenectomy in these patients. With excellent selection criteria, they have been able to achieve results which are stupendous to any of the gastric cancer studies you are looking at. Unfortunately, there are no randomized control trials, and it's very unlikely that it will be reproducible in any part of the world. Fortunately or unfortunately, it's not that common in the rest of the world, but the screening modalities that are being used in these countries, China, Korea, and Japanese populations, which are showing all these excellent results with early detection and interventions. To summarize, the surgeon should aim at an R0 resection in early gastric cancers which are chosen to be taken up for surgical upfront surgery. Those patients who have got locally advanced disease should be going for more than surgical modalities, non-surgical modalities to begin with, then surgery should be added. Total gastrectomy should be avoided if possible with good surgical resection margins. Modified D2 lymphadenectomy can be performed safely with no increased morbidity and mortality with excellent results, probably adding to the survival. Minimally invasive techniques can be adopted without having any adverse effects on these patients. Thank you very much.
Thank you, Dr. Srinivas. You are finished right on time. We'll keep the discussions for the end. Please, can you come and join us on the stage so that we can have the discussions at later.
Next speaker is Dr. Bhavana Sirohi. She's a senior consultant and head of Department of Medical Oncology at Mazumdar Shah Cancer Center, Bengaluru. She is going to speak on optimal treatment for cancer stomach from neoadjuvant to advanced disease. Dr. Sirohi.
Thank you, Dr. Hemant, and thank you so much, Dr. Reddy, for inviting me for this meeting. The scientific content and the lectures I've listened to have been absolutely amazing. So while the slide presentation is uploading, I just had a comment to make from the last presentation. The new AJCC system actually has 1 to 3 lymph nodes, 1 to 2 lymph nodes as N1. So I think maybe in the panel discussion we can discuss that as to whether we really need to remove the 15 lymph nodes or with D2 gastrectomy. The 15 lymph node criteria was an old one, whether we should go up to 25 lymph nodes. So this is something I think we can discuss later on. My remit is to talk on stomach cancer, neoadjuvant to metastatic. And thank you. So this is to move forward. Okay, thanks. Very briefly, Dr. Srinivas has given an excellent remit about surgery, but it applies to what I'm going to talk about, systemic treatment and loco-regional treatment with radiotherapy. The Dutch trial, all the trials that have been done with the lymphadenectomies from D1 to D3, the Dutch one and the pivotal Taiwanese trial, which was published in Lancet Oncology, comparing D1 to D2, D1 with D3, none of these trials actually have shown an overall survival benefit. And we know that there is so much perioperative morbidity. So why are we going on increasing more number of lymph nodes when we have excellent treatment modalities like systemic chemotherapy and loco-regional therapy with radiation, which can actually give you the same outcomes? So these are the various modalities that we will discuss for neoadjuvant adjuvant strategy, which is perioperative chemotherapy, surgery followed by chemotherapy, which is practiced widely in East Asia, surgery followed by adjuvant chemoradiotherapy, which is again level 1 evidence and also practiced widely in North America. And then you have neoadjuvant chemoradiotherapy. I will touch upon that briefly because there are trials running which will answer that question. So coming to perioperative chemotherapy, MAGIC was the pivotal trial published in New England Journal, led by the Marsden Group, where I trained with Professor Cunningham. The choice of regimen here was ECF. Patient received 3 cycles of ECF at the time of randomization. They were randomized to either surgery alone or perioperative ECF, followed by surgery, followed by ECF 3 cycles, and about 74% patients in this study had esophageal cancer. And there was a 13% overall survival benefit for ECF, which is perioperative chemotherapy arm, and no increase in post-operative complications. And this data was again replicated, very similar results by the French, but majority of the patients in this trial had lower esophageal cancer, but again 14% overall survival for perioperative chemotherapy. The chemotherapy here was a doublet, cisplatin and 5-FU. From Tata Hospital, we published this result last year in JCRT, where we looked at EOX is as good, as magical as ECF, and looking at EOX, 99 patients from Tata Hospital, comparing it to MAGIC and the French trial. In our study, which was a retrospective study, 93% patients were able to complete EOX. We lost 1 patient. In the MAGIC trial also, they had lost 1 patient. That was a treatment-related mortality. 86% patients were able to complete neoadjuvant treatment. And as you can see, it is very difficult at times to get an adjuvant treatment after surgery. And because of the morbidities associated with surgery, and also because of gastrectomy, the tolerability of patients to handle chemotherapy or chemoradiotherapy can be quite tough. So in our study, 60% patients completed adjuvant treatment. This is completion, that is compliance to 6 cycles of therapy. In MAGIC trial, only 42% patients were able to complete all 6 cycles in adjuvant and neoadjuvant. And in the French trial, it was about 50%. Coming on to the adjuvant chemoradiotherapy, I think this is INT 0116 led by the SWOG group, is the pivotal randomized trial where patients were randomized to surgery alone versus surgery followed by chemoradiotherapy. I think we've seen D1 and D2 dissection, but in this trial, a majority of patients, about 54% patients actually had a D0 to D1, less than D1 dissection. 36% patients had a D1 and only 10% patients had a D2 dissection. But despite that, there was a significant overall survival benefit in the favor of chemoradiotherapy arm given post-operatively. And also at the 10-year follow-up survival data which was published shows that the median overall survival remains in favor of chemoradiotherapy. But you must remember that this was a highly selected group of patients, because all patients had to have undergo surgery and recovered from surgery and then randomized to surgery versus the chemoradiotherapy arm. And there was significant grade 3 GI toxicity. About 33% patients had grade 3 GI toxicity. But again, one can argue that with improvement in radiotherapy techniques, this has gone down significantly. Coming on to the third modality, that is surgery followed by adjuvant chemotherapy alone, which is practiced in East Asia and majority of centers. CLASSIC was the key study which randomized patients to surgery versus surgery followed by capecitabine and oxaliplatin, which was given for 6 months for 8 cycles. And again, you can see that there is a trend towards prolonged overall survival, but a significant progression-free survival benefit. All the patients in this study had D2 lymphadenectomy done. Another study, which is again, S1 is not available in India, so I won't dwell on it, but again, patients randomized to S1 for a year versus observation, a significant survival benefit for adjuvant chemotherapy. Looking at meta-analysis of adjuvant chemoradiotherapy after 2006, because we say that, the techniques were not so good before, now we've become better with the techniques. You can see these all 4 meta-analyses have included about 1,000 to 2,800 patients, and all of them actually show that yes, there is a benefit for chemoradiotherapy given post-operatively, and in these studies, the morbidity related to chemoradiotherapy was much lesser than the INT 0116 trial. Looking at the meta-analysis of adjuvant chemotherapy, you will see the numbers are just double than what you have in the adjuvant chemoradiotherapy studies. The confidence intervals are shorter and a consistently significant benefit in favor of adjuvant chemotherapy. Looking at chemoradiotherapy versus chemotherapy, I think the ARTIST trial is the pivotal trial in which 100% patients had a D2 dissection, and patients were randomized to chemotherapy versus chemoradiotherapy. And they published 7-year follow-up data into this month in January 2015, which is the last row. And basically you can see that there is no disease-free survival or overall survival benefit for chemoradiotherapy versus chemotherapy. Both are pretty much similar, but the toxicity is more in chemoradiotherapy arm. What they did show was that in subgroup analysis, there was a benefit with chemoradiotherapy in patients who were node positive. So the ARTIST-2 is randomizing patients with node positive disease into chemoradiotherapy versus chemotherapy. So till the results of that available, we can't extrapolate it to node positive patients. Again, all of these studies basically show that both of them are pretty much equal and no significant benefit of one over the other. Small study of 68 patients by Yu et al. In 2012 does show that the 3-year overall survival was better for chemoradiotherapy, but this was highly underpowered. Very brief word about neoadjuvant chemoradiotherapy. I think the MD Anderson group by Dr. Ajani has published in small number of patients where they've given chemotherapy. All of these patients have had cisplatin 5-FU or taxane-based 2 cycles of neoadjuvant chemotherapy followed by chemoradiotherapy. And as you can see, majority of the patients are able to undergo surgery, and R0 resection was achieved in about 70 to 78% patients with a path CR rate of about 20 to 30%. So it is feasible and doable and safe, but I think we still need to wait for randomized data before this becomes a standard of care in stomach cancer patients. So you have various guideline recommendation. You have the European, American, Japanese, and we also published the ICMR guideline update in last year's Indian Journal of Medical and Pediatric Oncology. I would encourage you to read it. Basically, level 1A recommendation we've given for perioperative chemotherapy, and for post-operative chemotherapy or chemoradiotherapy also level 1A recommendation. This tallies in more with ESMO guidelines, and also you can replace 5-FU with capecitabine and also replace cisplatin with oxaliplatin, because again, giving ECF is quite cumbersome with a PICC line and also a 21-day continuous 5-FU infusion. It's quite tough on the patient, costly also, and you have a lot of line infection problems. With cisplatin, you have to give hydration, replace potassium, magnesium, more time in the daycare. So for patients' quality of life, oxaliplatin and capecitabine is better. And again, we've shown from the Tata data, even though it's retrospective, that the outcome is pretty much similar with EOX versus ECF. So these are the current trials, which is the MAGIC-B, randomizing patients to ECX versus ECX plus bevacizumab pre and post-op. So this will be the perioperative chemotherapy trial, which will be quite interesting to wait for. Then you have the CRITICS trial, where patients with resectable adenocarcinoma of stomach or type 3 OGJ are randomized to ECX perioperative chemotherapy versus neoadjuvant chemotherapy followed by surgery and then chemoradiotherapy. And the Top Gear study is actually trying to answer the question of neoadjuvant chemotherapy versus chemoradiotherapy to see which one actually would be better. So I think these trials will answer the question as to what should be the standard of care in the next 3 to 5 years. Coming briefly onto the metastatic gastric cancer, you have first-line setting where patients present de novo with metastatic disease, and you have patients who received prior adjuvant therapy. So I'll discuss second-line setting as well. Third line, very little data available now except ramucirumab, which is not available in India. So I won't discuss that much. And then targeted therapy. First line chemotherapy, what should be the standard of care? There is a meta-analysis published basically which shows that polychemotherapy is better than single agent. Combination of 3 drugs, which has an anthracycline, is better than infusional cisplatin 5-FU. And a 3-drug combination is basically better than a 2-drug combination. So REAL-2 was the pivotal trial which randomized patients into 2 by 2 into ECF, which is standard of care in most centers. Cisplatin was replaced with oxaliplatin and 5-FU was replaced with capecitabine. Again, to try and see, this was a non-inferiority trial, to try and see if these were equivalent, and for patients' quality of life, whether we could replace these, as I've said before. And as you can see, the arms are pretty much overlapping each other, but for EOX, which is epirubicin, oxaliplatin, and capecitabine, the survival was the most significant and the best. The rest of them, the median overall survival is about 9.9 to 9.3 months, but it was 11.2 months for the EOX arm. So it fared the best compared to the other 3 regimens. The other drug which is quite interesting in first-line metastatic setting, because we know epirubicin is cardiotoxic, and most of the patients, the median age of presentation of gastric cancer is usually above 60 to 65 in the Western studies. And you want to avoid anthracycline if possible because of comorbidities of diabetes and hypertension. So to try and replace epirubicin with docetaxel, this was a first study which looked at DCF versus CF and showed that, that adding docetaxel to CF actually leads to a significantly better overall survival. We from Tata published this last year. So where I looked at patients with advanced gastric cancer, we published it in Medical Oncology last year. We looked at 144 patients. These were all consecutive patients who walked into the clinic for the time period that I worked in Tata Hospital between May 2012 and June 2013. So we had at least 6 months of follow-up for each patient, and the median follow-up of the study was about 10 months. So 128 patients received first-line chemotherapy. The median age of the patients was 51 years, very different from the Western data. But again, this could be related to referral bias or maybe the younger structure of our population. 38% patients in this study had signet ring histology. Again, this is significantly higher compared to reported in the Western literature, where it is 18 to 20%, 18% from the SEER database. Majority of my patients received either capecitabine or oxaliplatin, mainly because of poor nutrition, poor performance status. They were not fit enough to receive a triplet, and also financial issues. 17% received EOX and 37% received DOX, which was given at 2 weekly intervals. Only 2 patients received trastuzumab. I'll talk about this in a minute. The median progression-free survival was 6 months, very much consistent with the Western literature, and the overall survival was 8 months. The response rates I looked at taxane-based versus non-taxane-based was pretty much similar in both the arms. 3 drug combinations did significantly better than 2 drug combination, and EOX actually had the best response rates compared to DOX, and again DOX had better responses than capecitabine oxaliplatin. In multivariate analysis, the only significant factor affecting overall survival was performance status and the use of taxane. But again, this is retrospective data and a small number of patients. But I think taxane is very promising. Patients who received second-line chemotherapy, about 39 patients were able to receive second-line chemotherapy, did significantly better. The median overall survival was 12 months versus 6 months in these patients. Briefly, to talk about trastuzumab, it is important that if you have a patient who has advanced gastric cancer, we should do HER2 testing, especially if you have a trial running with HER2 positivity, or if the patient can afford trastuzumab. It should not be done in patients with early gastric cancer, because there is no data to show that trastuzumab should be given in early gastric cancer. But in advanced gastric cancer, it should be done. TOGA was the pivotal trial which randomized patients to capecitabine cisplatin versus capecitabine cisplatin and trastuzumab. And as you can see, that there was a significantly better overall survival for patients who received trastuzumab. For second-line study, I'm showing this Cougar study which looked at, which has been published, which looked at randomizing patients to docetaxel versus best supportive care. You have another study which has randomized patients to irinotecan versus best supportive care, and irinotecan and docetaxel both. So in second-line setting, I think whether you use docetaxel or irinotecan is equally good. If a patient has received docetaxel in first-line setting, I think it's fair enough to either give epirubicin-based or irinotecan-based chemotherapy as second-line treatment. This is a third-line study with ramucirumab, again, good overall survival benefit, but it's not available in India. So just to conclude, for first-line, I think all of these regimens have level 1 evidence. So you can have ECF, EOX, EOX, EOF, or CF, whichever. If patients have had prior adjuvant treatment and if they have more than 3-month DFI, the same doublet can be used. For second line, as I said, you can use either docetaxel or irinotecan. Consider trastuzumab for patients who are HER2 positive. So I was part of this management of gastric cancer in Asia resource stratified guidelines. I won't discuss this in detail, but I think you should read it up because it was published in Lancet Oncology, and it does tell us about what is commonly used in Asia. And also I would urge you to go through the ICMR consensus document that we published in gastric cancer. Thank you.
Thank you, Dr. Bhavna. If you can join us, we'll take the questions after the last speaker finishes.
Last session today is what's the role of radiation hepatic metastasis? The speaker is Professor Edgar Van Duzer. He is Vice Chairman for Translational Research, Department of Radiation Oncology, University of Pennsylvania, US. Dr. Joseph.
There's some technical difficulties here, so I'll start by thanking the organizers for inviting me here to give this talk. Thank you very much. And also apologize for my voice. I hope it holds on trying to recover from a cold, so hopefully it could last through this talk and the next one. Okay, so the topic this morning is radiotherapy for liver metastasis. And first, a little bit of a background. Radiotherapy has not been used very extensively in liver cancer or liver metastasis because 40, 50 years ago, very poor results have been reported with whole liver radiotherapy at that time. The objective responses were low, of the order of 10%, median survival was very low, and it was associated with very high toxicity. It was called radiation hepatitis, although we know it has nothing to do with hepatitis today, but the tolerance to the whole liver to radiotherapy was very low. You couldn't give more than 30 gray. And this radiation hepatitis that we today call radiation-induced liver disease, RILD, is essentially a veno-occlusive disease, and it's clinically manifest as ascites, hepatomegaly, increased liver enzymes. It occurs within 2 to 4 months after completion of radiotherapy, and there's no treatment for that except for symptom management, diuretics and paracentesis. It can also be fatal, although commonly it's not, and it's just a chronic condition. The foundations of modern liver radiotherapy have been led by the group at the University of Michigan, and this is a seminal paper by Laura Dawson and my previous chair, Ted Lawrence. Essentially, they have developed a normal tissue complication probability model that you see here, where you can predict the risk of radiation-induced liver disease based on the mean dose to the liver. And you could see that for 30 gray whole liver radiation, you run a risk of approximately 5%. But as you go above 30 gray into the 40, you start running into 25 and higher risk of radiation-induced liver disease. They also published that while the whole liver is very sensitive to radiation, you could irradiate small parts of the liver to almost any dose that you wish. So, for instance, if you're looking here at 1/3 of the liver, you could see that you could go to doses that are very, very high, and the risk of complications on the far right end of is almost nothing at 90 and 100 gray. So based on the understanding of these dose-volume NTCP relationships, the University of Michigan group had embarked on 2 trials. The first one was a phase 1 trial reported by Dawson and JCO in 2000, in which the radiation dose to the tumor in the liver was escalated based on that particular person NTCP. Essentially, increasing the dose until you hit a normal tissue complication probability of 15%. So each patient receives the highest dose of radiation that they can receive given their configuration of liver and tumor. And after the phase 1/2, we embarked on a phase 2 trial, which I reported back in 2005 in JCO, that established that this is an efficacious approach. That phase 2 trial included 128 patients. There were unresectable primary tumor or metastatic tumors. They all failed chemotherapy, and they really were not candidates for any other type of treatment. These were large tumors. The median diameter was 8 centimeters, and the dose, again, was individualized based on the normal tissue complication probability, and that normal tissue complication probability was driven to 10 to 15%. Therefore, the dose varied between 40 and 90 gray. The median dose was 60.75 gray. And there was also concurrent hepatic artery floxuridine infusion as a radiosensitizer, although today, in retrospect, we don't think that this was an essential component of the treatment. And these are the results of the trial, and I want to sort of draw your attention to the panel. Let's see if I can operate this. There's no, I cannot point. I'll try and point here with the, if you could, there's no, oh, there it is. So there's a clear dose response for local control and survival. And you can see that patients, this is the curve for patients who receive a radiation dose of greater than 75 gray, they did far better than patients who received lower doses. And you can see these two at the bottom, models for disease-free survival, or local control actually, I'm sorry, or survival. And they're both highly dependent on radiotherapy dose. The higher the radiation dose, the better the survival and the better the local control. On a multivariate analysis, the radiation dose was the most important factor determining how long these patients survive. And here's an example. I mean, pictures we relate to pictures very well. So you can see on the left-hand panel the pre-radiation large-sized tumors, and on the right-hand panels the tumors 6 months after completion of radiotherapy. Okay, so I'll now describe a very practical approach that I take to the treatment of liver lesions, including liver metastasis with radiotherapy. Very large tumors are, in my mind, mostly suitable for fractionated external beam radiotherapy, and I think that intensity modulated radiotherapy or proton therapy are probably the best way to go about it. Small tumors of the order of 5 to 6 centimeters or smaller are best suitable for stereotactic body radiotherapy. In the next few minutes, we'll talk about these modalities. So with external beam radiotherapy, the question is how to improve the therapeutic ratio. So one thing that you want to do is you want to minimize the volume of uninvolved liver that you irradiate, because the more radiation you give to normal liver, non-involved with cancer, the higher the mean liver dose is, and the less dose you can actually deliver to your target. In order to do that, to minimize the volume, it's essential to reduce tumor motion. You can also improve target delineation and localization. The better you localize it, the better you delineate it, the smaller the volume will tend to be. We'll talk about increasing the radiation dose. You could do this very well with IMRT, with protons, with carbon ions. And you can individualize complication risk prediction. And I'll talk a little bit about how you do this with a functional assay of liver function, indocyanine green, or what I'm doing at the University of Pennsylvania with a collate assay. So elimination of breathing motion. I'm showing two common devices of how you can treat patients at breath hold. Clearly, on the left, it's an SDX device made by a French manufacturer. On the right is one that I've used more commonly at the University of Michigan, the active breathing control system. And essentially, the patient breathes into a mouthpiece, and it's a spirometer, and you can monitor their in and out tidal volume on a computer, and you can hold their breath, or the patient holds their breath at any particular time. And that's how you plan the patient, and this is also how you deliver the radiotherapy. What are the consequences of liver motion, liver tumor motion? This is a classical paper by Randy Tenhaken from the University of Michigan. It's an old paper from 1997, but you could see, particularly on in the right table, that if you eliminate motion, that is, if you treat patients at breath hold, then the dose that you gain is about 8 gray. Now, if you remember the dose response curve that I showed you before, 8 gray would take you roughly 6-7% up on the tumor control probability, and this is also shown in this table. So this is not a trivial amount. I mean, we talked about, the previous speakers have showed you studies that give lots of chemotherapy and lots of radiotherapy for a 5% increment. You get at least that with simple measures like managing breath and giving a high dose of radiotherapy because you are managing breath and you're irradiating smaller volumes. IMRT can also significantly reduce the dose to the liver, the liver dose, and that was shown by M. Thomas, also from the University of Michigan group, also quite a few years ago. And what we have shown there is that if you use IMRT compared to 3D, you gain roughly anywhere between 11 and 18 gray of dose that you can deliver to the primary tumor or to the metastatic deposit if you use IMRT. So I think that IMRT is clearly advantageous over 3D in liver cancer. Lastly, proton therapy. These are the proton facilities that we have at the University of Pennsylvania, and it's a very costly sort of facility, but I understand that there will be a few proton facilities here in India also very soon. And the big advantage of protons, if you see the depth-dose relationships, if you look at the bottom, the blue line, this is the entrance dose for protons is usually far lower than it is to photons. You treat the target, your tumor there, and then the dose falls off to 0. So there's no exit dose. So you could see that you could treat the target very similarly, but with far less dose to the liver, if you were using this thing to treat liver cancer. And here I'm showing a comparison of a liver lesion planned either with protons, that is on the right-hand side, or with rapid arc, that is on the left side panel. And at the bottom you see the difference in the dose volume histograms. And you can see there's a substantial sparing of normal liver with protons. Now this has been tested already in at least 2 phase 2 trials. The top trial is a trial from Loma Linda in California. And the second one is a Japanese phase 2 trial. This was not in metastatic disease, this was in hepatocellular carcinoma, but the principles apply. And if you look particularly at the Japanese data, 45% 5-year survival for unresectable liver cancers is unheard of. It really rivals the results of surgery. So it's a sort of a proof of principle, although not complete proof that this is the modality that we should use, but it's a very, very strong signal that this is the way to move forward on liver cancers. Okay, lastly, individualization of therapy, icy green. So indocyanine green is a green dye that you inject intravenously, and the rate at which it is extracted by the liver can be used to predict or to measure liver function. And if you, this is from the University of Michigan in a trial that I initiated in 2003 there, and recently was reported by my colleagues there. I've moved since from the University of Michigan. And what you can see these plots on the left-hand side are patients who received, who did not develop radiation-induced liver disease, and the open dots are the ones that have developed radiation-induced liver disease. And you can see that if you measure clearance of indocyanine green a month after completion of treatment, there's a very nice separation in those rates between those who develop and those who do not develop radiation-induced liver disease. Based on that, a phase 2 trial was initiated then and reported recently by Mary Feng from the University of Michigan in 2013. They put 46 patients on a trial, and they gave them a first part of a course. This was all SBRT, so the median planned dose was 50 gray. They gave them 3 fractions. Prior to treatment, they measured indocyanine green clearance. They waited a month. They measured indocyanine clearance again. And based on changes, they either stopped treatment altogether if there was a deterioration in liver function, or they modified the dose, or they have continued as planned if there was no significant change in the clearance of indocyanine green. And what they report is that the local control rate at 1 and 2 years in these patients were 96 and 68%, and they were very, very similar to the previous SBRT experience at the University of Michigan. But while doing that, they actually modified the dose in 13 patients, 28% of their patients received only 3 fractions, and another 5% had a dose reduction. So the rate of radiation-induced liver disease was reduced by this approach, but the local control was identical. Okay, and in 2 words, collate assay is a very similar assay to the indocyanine green, but it's a little bit better. It has been looked at in a large hepatitis C trial, and it's the best functional assay that we have today for liver function. And I just started a clinical trial trying to do similar things with this assay at the University of Pennsylvania, as I showed you at what we have done at the University of Michigan. Okay, stereotactic barrier therapy. We have 5 more minutes, so I'll try to finish on time. SBRT is a way of giving very high doses of radiation per fraction, and the rationale for that is that when you do this, when you give very large doses at very large dose per fraction, the bioeffectiveness of this thing is far, far greater. Essentially, these are ablative treatments. There's not too many lesions or cells that can withstand such a high dose. It's a shorter duration of treatment, and usually it's associated with a reduced cost as opposed to a fractionated 5, 6, 7 week course. The initial experience with SBRT for liver lesions was a German experience reported in JCO in 2001 by Herfahrt. It was a phase 1 study. I'm not going to dwell on that. We don't have much time. Suffices to say that their results were very promising, and this led to a whole wave of SBRT for liver cancer. What I do want to spend a few minutes on is this trial, which is a seminal trial published in JCO in 2009, Rusthoven. And this was a multi-institutional trial led by the University of Colorado. And they treated patients with 1 to 3 liver metastases, tumor diameters, as I said, up to 6 centimeters. You can see the rest of the eligibility criteria. It's not too difficult, and these criteria, the rest of the criteria, are not too restrictive. The SBRT schedule was 20 gray times 3. The constraints is that you have to keep at least 700 cc's of normal liver below 15 gray. You can see in the table the patient characteristics, and interestingly, you can see the number of lesions treated at the bottom. So most of these were a single lesion treated, but there were up to 3 lesions that were treated in that trial. And these are the local control and survival data. I would not pay much attention to the survival data. I think that they selected patients that died very quickly. I think that it was a fairly early trial. In the future, we'll select patients who have probably a better probability of survival, who could benefit from this approach more. But on the left-hand side, you can see the local control rate. And the local control rate was superb. It's of the order of 90%. So how does SBRT compare to, for instance, radiofrequency ablation? We were very interested in this at the University of Michigan. We have competing modalities for the treatment of single or 2 liver metastases. And we looked at 127 patients treated with RFA within this period of time versus 62 patients treated with SBRT. Again, this is how patients were treated at the University of Michigan with ABC, 20 gray times 3 or 10 gray times 5. These were the most common regimens. If you do this with a radiofrequency ablation, you need usually general anesthesia, ultrasound guidance, an electrode system. You need margin sizes, and it's a little bit more involved procedure. These are the patient characteristics. I'm going to skip this. They are fairly matched patients. The median tumor volume was 90 C, so the diameter was 0.2 to 7.6 centimeters. The dose was quite high. The median BD was 100 gray. And these are the results. You see that the 2-year local control, freedom from local progression rates, for RFA is 83%, for SBRT is 84%. So essentially, they are identical. This is on the right-hand panel. If you look at hepatocellular carcinoma, the results of SBRT are actually better, or at least they seem better in this small series. And interestingly, it's highly dependent on size. So what you can see in this plot is that patients with lesions more than 3 centimeters in size actually do far better with SBRT than they do with radiofrequency ablation. And the complication rate with stereotactic body radiotherapy is far lower than it is with radiofrequency ablation, 0.9 versus 3.9, and they actually had a death within 30 days of RFA in the RFA series. So in conclusion, SBRT achieves excellent local control with low toxicity. SBRT is more effective than radiofrequency ablation for liver tumors more than 3 centimeters. And finally, you ask yourself, so what are the long-term results of SBRT? There are not too many series or trials that have looked at that, but I picked one. In patients with liver metastasis from breast cancer, for instance. And I'm just showing here the local control rate at 6 years is 87%. So if you look at these patients who live long, you could see that the excellent local control is maintained over long periods of time. I have more, I can show you here more data, but I think we're running out of time. I just want to highlight a trial in colorectal metastasis, which shows also superb results, and maybe you can look up this excellent paper by Scorsetti on your own. I think that's all I have. Thank you very much.
Thank you, Dr. Joseph. This being a new topic, there will be a lot of queries.
Can I request Dr. Srinivas also to join us, please? Now, all the 4 topics are open for discussion. First, we invite questions from the floor for all the 4 speakers.
Good morning. I am Dr. Pratap Reddy, surgical gastroenterologist. My question to the panel is, if suppose one of you gets T3, N1, M0 carcinoma stomach, adenocarcinoma, is there a consensus as to what is the best treatment?
Yeah, I think that's a very good question. So I would probably ask Professor Rogi to start and then.
See, as we discussed for T3N1 disease, it's in the locally advanced territory. So my practice would be that we would consider the patient for perioperative chemotherapy. We would give neoadjuvant chemotherapy. But if you want to go for surgery upfront also, that is not the wrong option. And you can, based on the histology, go for adjuvant chemotherapy or chemoradiotherapy. That is also level 1 evidence. The other thing I wanted to say about was, in this patient, we should consider doing a diagnostic laparoscopy and peritoneal cytology. And because most of us in India, what we do is we do the diagnostic lab, but not the peritoneal cytology. And if the cytology is positive, then the Japanese data is there that you give neoadjuvant chemotherapy. That patient should definitely go for neoadjuvant chemotherapy. And if the cytology becomes negative, there is some data to show that you can still proceed for surgery. But if the cytology remains positive, this patient should not be taken up for surgery and should be treated as palliative. So, that defines the intent of treatment for the patient.
What is the perioperative chemo you give? What is the schedule?
We give, I have actually, ECF is very cumbersome, and even Marsden, where they started this magic ECF, they replaced it with EOX. So epirubicin, oxaliplatin and capecitabine.
This magic trial, I always had a feeling there was no adjuvant arm. The comparison was only with the surgery alone.
Yeah.
Suppose you had an adjuvant giving continuous 21 days, 5 of you, maybe you might have had the same result.
Possibly. That's why the other trials, which are randomizing patients to adjuvant chemotherapy versus the critics trial, is randomizing to adjuvant chemo versus chemoradiotherapy, and everybody is getting preoperatively. So I think that trial will answer the question, because you are right, the surgery arm had no, and plus in this study, a lot of patients had node negative disease.
and distal cancers did not respond that well. Probably the T3N1 is going to be distal cancer. Probably you're better off taking it for a direct surgery if it is resectable after a laparoscopy.
Yeah, the reason I raised was exactly to expose this part.
Yeah.
You know, despite discussing so much, we still have no consensus. I think every few years, the entire oncology group, surgeons, medical radiation oncologists, at least should publish standard of care guidelines regarding stage-wise management of the disease, which will be accepted in a court of law also.
But this is standard of care what we discussed, and this is based on randomized evidence. Further randomized evidence will make things even more clearer.
We do talk about standard of care and we talk about appropriate care. Now, if the patient has got gastric outlet obstruction at the same time he has come to you for treatment, probably the surgeon would err more on the surgical side rather than with neoadjuvant chemotherapy and neoadjuvant chemotherapy.
I would agree with that, but sometimes the surgeons, like working in Tata Hospital, the waiting lists are huge and with long. So at that time what we do is we put a nasojejunal tube and then we go ahead with the neoadjuvant chemotherapy, or we give ECF or EOF, where we replace capecitabine with 5-FU and give it intravenously, continuous infusion. But in some settings, I think because of waiting lists, you don't have the option to go for surgery. You just go for chemotherapy perioperative.
There is somebody had a question.
If I may just add a question about, somebody asked also about radiation. In the McDonald study, these would have gone on to get post-operative chemoradiation, and there was a survival benefit from that because the caveat is most of those patients had deep resection. In the Artist study, had a D2 resection, and those who were node did have a benefit adjuvant post-op chemoradiation.
I think somebody had a question there.
Yeah, my question is directed to Bhavna. Bhavna, you have any experience about HER2 locally advanced gastric CAs where the regimens which is currently used with trastuzumab? Since we discussed that EUX is probably a better regime than others, is it possible, like two drugs, trastuzumab and epirubicin, to use the same group of patients?
So again, I do the same thing. I do, the trial was with cisplatin 5-FU or capecitabine cisplatin. I replaced cisplatin with oxaliplatin, so capox plus trastuzumab with very good results in metastatic, not locally advanced. Locally advanced, there is no data.
My question to Dr. Edgar as well. Sir, you have been doing assisted breathing for all patients taken up with SBRT in liver?
So we do, if they can tolerate that. There's probably about 10 to 15% of patients who cannot follow instructions or do not do well with this. And then what we do, we simply do a 4D scan, we construct an ITV, and we treat an ITV. If you do SBLT with that in patients who live in metastases, you could probably get by with that with no difficulty. But particularly if anyone has poor liver function, it becomes very critical. And the bigger the lesions, I think the bigger the advantage. But you don't absolutely have to use breath hold treating SBLT with small lesions.
Can you recommend proton therapy routinely outside of a clinical trial or SBRT outside of a clinical trial routinely? Because there is no randomized data, which is what we consider as gold standard, compared to let's say other modalities for liver treatment like TACE or TARE or other treatments.
Right, so if we're talking about liver metastasis, for most of the other modalities we have for liver metastasis, there are no randomized trials. I think that the results of SBLT, surely you could use that as standard of care outside of clinical trial. I don't think that you need to put patients on clinical trial to treat them with SBLT. The proton trials also, we treat them routinely. We have clinical trials, but patients who do not want to go on clinical trials, we also use protons outside of clinical trial for large liver cancers. I think some things I understand the need for randomized phase 3 trials, but not for everything. And when the differences are striking, and I think the signal is striking, I think that that's good enough for most people.
If you are looking for a gold standard for a mastectomy, probably it is still the surgery, but that doesn't have a level 1 evidence. The standard thing which they say is they show the parachute and they say you want to have a level 1 evidence to say when you want to jump with a parachute or without a parachute.
In colon, you have evidence with the URTC.
Yeah, but when it started and became popular, there was no,
Yeah, just talking about level 1 evidence, lung people tried to generate level 1 evidence for SBRT. You know, the Amsterdam group, the CyberKnife group, and there were various trials instituted. But because of the need of a lot of patients and somehow accruals not being so great, things fizzled out. And I don't think the accruals have been so. To generate level 1 evidence in this kind of a setting is not easy. So if we have a large series of a single arm trial, a prospective trial, or just a single arm trial, and if we can show equivalence, I think presently that solves the purpose. But of course, we should be aiming for a level 1 evidence and randomized evidence in due course of time.
I think that was that's the last question. We have a paucity of time.
Basically, how to sequence the treatment of the primary when we are treating liver metastasis by SRS or SRBT, and management of the toxicity. And primary could be anywhere.
Could you please repeat your question, please?
How to sequence the treatment of the primary with respect to SRS or SRBT liver metastasis and management of the toxicity profile?
So, as I said, if you have someone who's a surgical candidate and this lesion, liver lesions, is resectable, then the patient could have a liver resection plus resection of the primary at the same time. That would be the ideal situation. That's how we practice at the University of Pennsylvania and other places. If that's not feasible, then there's a variety of different schemas, and I think every institution does it a little bit differently. I don't think that there's an agreed upon sequence that works better than others that everybody could agree on. Usually, if the lesions are big, not resectable, we might start with chemotherapy. After chemotherapy, we might continue with chemoradiotherapy and then resect the primary, then at some point address the liver metastasis, but there's very, very many ways of sequencing this thing.
Thank you, sir. I think there might be a lot more questions we can discuss over tea. I thank the organizers for organizing such a good debate, such a good discussion. I'm sure everybody has benefited from this kind of a talk that we have had in multimodality setup. And I thank all the speakers who were there, who came, and we had this great discussion. Thank you very much.
Thank you very much, Mr. Chairman. Ladies and gentlemen, we move on to the next session. The beverages continue. We have 4 lectures. The first 3 lectures would be for 17 minutes each, and the last lecture would be for 25 minutes. And we'll take up the last 10 minutes for discussion at the end of all the 4 talks. May I request all the speakers to kindly bear note of the timer that's straight across the podium. With these few words, may I invite our chairpersons, please welcome, in the order of appearance, Dr. Kaustav Talapatra. He is a senior consultant radiation oncologist at Kokilaben Dhirubhai Ambani Hospital and Research Institute from Mumbai. Flanking him is Professor R. Pratap Reddy, Head Department of Surgical Gastroenterology at the Osmania Medical College Hospital in Hyderabad, Telangana. Gentlemen, the stage is all yours. Thank you very much.
We'll start without wasting any time. The first speaker is Mahbub Basade. He'll be talking on new hope in metastatic colorectal cancer treatment, role of regorafenib. I invite Dr. Mahbub.
Good morning and thank you, Chairperson. Again, let me thank Dr. Vijayanand Reddy for inviting all of us here. Regorafenib talk was supposed to be given by Dr. Bianchi, who is from Italy, but he couldn't come because of his ill health, so I am the replacement for him. So I will discuss whatever the slides he has provided to us, and let's look at what's there in new regorafenib. It's a new kid on the block for the management of metastatic colorectal cancer. So it's a very novel oral, very important, that multi-kinase inhibitor. It inhibits a lot of pathways, and you are aware that for any tumor to grow, you require an angiogenesis, you require tumor signalings for the cells to grow, and all those things are interlinked with each other. And there are upstreams and downstreams pathways. For example, if you look at here in the tumor cell, endothelial cells and pericytes all interacting with each other, and all these things will ultimately lead to the tumor cell growth and further metastasis. And all these pathways can be very well blocked with the new regorafenib, which you can see it inhibits basically the oncogenesis, angiogenesis, and the tumor microenvironment. So microenvironment in the pericyte and the other surrounding the tumor are also inhibited because of the regorafenib, which is an oral multi-kinase inhibitor. The pathways which are blocked basically is angiogenesis through the VEGF 1 to 3 blockways, and TIE2 pathway is a very important pathway. So it's a distinct from the others. It blocks the tumor microenvironment with the help of the blocking the PDGFR and FDGFR pathways, and oncogenesis through the KIT, PDGFR and RET pathways. And as it acts on the KIT, as you are aware, that KIT pathway is also required for the development of the GIST. This drug has also been tried in the GIST, just to give an information. So this is a very important multi-target kinase pathways which are blocked by this drug. It's a simple oral drug. It's available as 40 milligram tablet, and the daily dose is 160 milligram. The protocol given is like 3 weeks on and 1 week off. And this drug is metabolized by the liver. So it's very important that the liver functions are normal before we start. Regorafenib has been tried in the phase 1 trial, and it has been found to have very effective results. So straight away it moved into the phase 3 trial, and I'm going to present the two phase 3 trials, that is a CORRECT and CONCORD trial. CORRECT trial, this is the phase 3 data. The CORRECT trial was done in almost 750 patients across the countries, and majority of the countries, the patients were included were from the West. And there is an Asian study known as CONQUER, where the patients were mostly from Far East Asia, like China, Hong Kong, Taiwan, and other things. There is a distinction between the enrollment in these two studies. In the CORRECT, the patients were included at least should have one targeted therapy received in the prior therapy, apart from the chemotherapy failures, like bevacizumab or cetuximab or panitumumab, while in CONQUER that was not mandatory. So they may have received at least 3 lines of therapy of chemotherapy, but no panitumumab or cetuximab or other things. And the ECOG performance status for all these things required was 0 to 1. So let's look into the CORRECT, and I will give you about the CONQUER later on. This is used in metastatic colorectal cancer. 2:1 randomization, patients receiving 160 milligram of oral regorafenib versus placebo plus best supportive care, and this was continued till the disease progression. One cycle is called of 1 month, where 3 weeks therapy is on and 1 week is off. Almost 750 patients were included, and if you look into the criteria of inclusion, the disease progression during or within 3 months of the therapy. That means these are really the poor patients who are doing poorly on the treatment, either with chemotherapy or chemotherapy plus bevacizumab or cetuximab. So poor risk patients, and there is no option in the third line therapy, and such group was included in the CORRECT trial. And you can see from here as well, a lot of patients, more than 73% of the patients in regorafenib arm received more than 3 lines of prior therapies. and almost all drugs were already given to such patients. There has been 51% reduction in the risk of progression or death on the patients who were receiving the regorafenib arm. Median progression-free survival was 1.9 months versus 1.7 months, with the hazard ratio very impressive, 0.49. You will feel that 1.09 was 1.9 versus 1.7 is hardly there is a difference. But if you look to the further overall survival, it reduces further 23% reduction and with hazard ratio of 0.77. This means that the patients who have received the chemotherapy plus targeted therapy in the earlier arm are doing little better when there was no option. There is no biomarker for this drug, and it works irrespective of the KRAS status, irrespective of the patients received either cetuximab or bevacizumab or what kind of chemotherapy, and irrespective of the time from the first diagnosis. I was mentioning about the hazard ratio, and if you look at the hazard ratio for this cetuximab study used in first line therapy like FOLFIRI plus cetuximab, hazard ratio was 0.8 in first line. In second line, FOLFOX plus bevacizumab, hazard ratio 0.75. And if you see in third line with bevacizumab, you have a hazard ratio of 0.77, indicating that this is the preliminary phase 3 study showing there is an improvement in overall survival, which is statistically significant, and a good hazard ratio. One more important thing to remember, the patients who received this regorafenib had stable disease. There was no complete response, and only 1% of the patient had shown the partial response. So what we are going to achieve by giving the regorafenib is make the patient stable. And disease control rate was somewhere around 40%. Concur is another phase 3 trial from the East Asia. Almost 200 patients were included from the 25 centers, and the dose was again same, 160 milligram in 3 weeks on, 1 week off versus placebo plus best supportive care. And in this study, as I mentioned, that there was no mandatory requirement of any targeted therapy. This study also showed that progression-free survival in the patients who have not received any targeted therapy, in fact, is better, 3.2 months versus 1.7 months in the placebo, which remains the same, indicating there is a 69% reduction in the risk of progression or death on the patients receiving regorafenib arm. And if you look at the overall survival was 8.8 months versus 6.3 months. And the same 8.8 months progression overall survival benefit is seen the patients receiving the cetuximab also. So there is a 45% reduction in the risk of death in the patients receiving the regorafenib. And in this study also, there was no subgroup, and most of the subgroup analysis showed in favor of the regorafenib, and no biomarker was been found to be important. It works irrespective of the KRAS status. Again, disease control rate in the Concur study also stable disease, and almost 45% of the patient, partial response was in 4% of the patients. So overall 51% of the disease control rate was seen, which was nearly 7 times that of the placebo. How safe it is, because you are giving oral medication and it has a multityrase kinase activity. So obviously we know that all TKIs which work through the EGFR pathways have hand-foot skin-like reaction. This drug also has a hand-foot skin reaction, which was seen in any grade in almost 70% of patients, and grade 3, grade 4 was hardly in almost 16% of the patient. In both the studies, equally, in fact, you have a consistent adverse event reaction. Blood bilirubin increased, raised enzymes of ALT was also seen. There was change in voice, diarrhea, fatigue. These are the common side effects which are seen the patients receiving the regorafenib, and these side effects are seen mostly into the early 1 to 2 months, in the first 1 or 2 cycles. As you can see from this graph, over a period of time, the toxicity pattern also decreases and patient gets stabilized. So it is recommended that the patient who are on regorafenib arm should visit you every weekly in the initial 1 to 2 months. When you see the rash, you try to manage them as early as possible. And how to manage the adverse events is by either reduction in the dose or the schedule adjustment. Supportive care is also important, as what we do for the management of the hand-foot syndrome with the other like sunitinib or sorafenib. Same thing can also be done using the gloves and stockings and other things. So management is easier. First 2 cycles are important. It is a non-cumulative toxicity, and it's very convenient to give to the patient as it is in the oral form. The minimum dose which is required is 80 milligram, and if the patient is tolerating well 80 milligram, you can step up the dose to 160 milligram, which is a better dose. And where, as far as the guidelines are concerned, where this molecule is placed at present is that the patients who are having a RAS mutation, obviously you are not going to give cetuximab or panitumumab. These patients will receive the bevacizumab first line along with chemotherapy. The second line bevacizumab inhibitor, whichever people may try, or people can continue the bevacizumab in the second line as well. And these patients, when they fail on the two lines, then the regorafenib as a single agent. See, it is not combined with any chemotherapy. The single agent at present has been tried, that too in the third line therapy. And the patients who are RAS wild type, they will receive some sort of anti-VEGF therapy plus EGFR therapies in either of the sequence. And those they fail, then they will go for the regorafenib. So it's either in the third line or fourth line therapy in the patients with the RAS wild type. And BRAF again is the same in the third line therapy. People can use this regorafenib. It's a good drug in the oral form, can also be used. It has a unique mode of action targeting the tumorigenesis, angiogenesis and tumor environment. This is the first of oral multi-kinase inhibitor with the proven efficacy in metastatic colorectal cancer. Remember that there is no oral drug in metastatic colorectal cancer as far as targeted drugs are concerned. There is a survival benefit seen in the 2 large phase 3 trials, and it has proven to efficacy in the patients who have been previously treated with some sort of therapy. Those patients who are receiving the chemotherapy only, like in Conquer, are having a better survival advantage as compared to the patients who have received some targeted therapy in their previous lines of therapy. So it's a well tolerated. AEs can be very well managed by dose reduction and the schedule adjustment. And I think we have some more oral option available for the patients of colorectal cancers. Thank you. I think I am before the time, 4 minutes. So if you have any questions, please, or at the end.
Thank you, Dr.
Cost of the drug. Cost of the drug.
Cost of the therapy, I think the people from the Bayer are available over here, and what they told us that per month cost would be around 1.4 lakh rupees. That's the one cycle course, but they are going to assist the patient like what we have, the patient assistance program for all other things. So the Bayer probably will tell you better.
Yes, finished.
If there are no questions.
Any other questions? You can also ask questions at the end of the session.
Thank you.
Thank you, Dr. Mehboob.
Now we go on to the next talk. May I invite Dr. Surya Nalamati. He's a senior consultant colorectal surgeon and robotic surgeon at Henry Ford Hospital, Detroit. His talk is going to be on robotic surgery for colorectal malignancies. Does it have an edge? How we attach the expertise. Dr. Surya Nalamati.
With the permission of the chair, can we have the speaker's microphone on, please? Thank you.
Hello. I thank you all. Thank you, Apollo Group, for giving me the opportunity to present today, especially Dr. Vijayanand Reddy, to invite me for this session. And I'm happy to be back. at the place where I did my training. I trained from Osmania Medical College and Kakatiya Medical College, and I see many of my teachers here. Dr. Pratap Reddy might not have remembered me, but he's one of my teachers, and Dr. Subramanyeshwar and Dr. Suresh are also in the audience. I thank you all from the bottom of my heart for the training you imparted on us. We'll go out with our presentation. I think it's up. My talk today is about robotic surgery, and every one of you know that recently the robotic surgery has been introduced about like 10 years ago and is catching up, and I want to talk about the roles of the robotic surgery, what is the, especially in the perspective of colorectal cancer, what are the advantages or disadvantages, and what is the evidence right now, and what are the outcomes of the procedures we're doing, and what are we looking at in future. There's a gradual evolution of surgery. We've been doing open surgeries with large incisions, and around the 1960s, the gynecological surgeons have adopted laparoscopic surgery, and the general surgery faculty was slow to follow up on it. And in around 1988, we did the first lap cholecystectomy and the lap colectomy in 1990s. From then, we actually adapted laparoscopic surgery for colectomies very well, but it has not taken the speed as we intended. 25 years down the lane, we're still only doing 30% of our colectomies, even in the United States, laparoscopic. The rest are being done open. To overcome the deficiencies and inefficiencies posed by the laparoscopic surgery, we resorted to the robotic surgery in hope that this would overcome some of the deficiencies and challenges posed by the laparoscopic surgery. The first robotic surgery was done in 2002 by Weber, and it's almost 10 to 12 years since it was done. Currently, about 3,600 cases of colorectal surgeries are being done robotically in the United States, which is only 2 to 3% volume of the laparoscopic surgeries being performed right now. What are the advantages of the robotic? We have talked at length about the advantages of the robotic surgery before. The main advantage is it offers a stable camera platform. It increases the dexterity. It has 7 degrees of movement. We know that laparoscopic only offers 4 degrees of movement, so we have another 3 degrees of added dexterity that increases the quality of surgery being done. And the 3D vision also improves the quality of the vision we have and the precision of the surgery. The motion scaling, which is seen in robotic surgery, actually decreases the movement of the hand. So you can actually temper the movements of the hand so that the surgery is more finer and you eliminate the shape. And of course, the ergonomics of the robotic surgery are better. Apart from that, robotic surgery now is being done for almost all colorectal cancer procedures. But what we need to look at is there a benefit in doing everything robotic? We're doing right colectomies, left colectomies, APRs, low anterior resections, and recently transanal TME procedures are being done, and there's an interest in doing these robotically also. Leela Prasad from Chicago. operating times, which is one hour more, and the costs were high. Another trial done by staff now, he looked at 236 patients. Now, he did 3 arms in a study. He did a robotic arm with intracorporeal and extracorporeal anastomosis, and a laparoscopic arm with only extracorporeal anastomosis. When he compared all the 3 arms, he found that there was longer operating time for intracorporeal anastomosis, but he noted that the patients who had intracorporeal anastomosis had shorter hospital stay and shorter time for the first platters. So what do we take from this? I think robotic right hemicolectomies can be done, but we should not use the robot as a hammer for every nail we see. I think it should be very selective in doing robotic right hemicolectomies. I don't feel that there is significant benefit. What about the robotic LEVs, low antidotes, and rectal cancer dissections, the TMEs? As we all know, Heel came up with the idea of a total mesorectal excision. He gave us the planes of total mesorectal excisions, and we grade our excisions as complete, nearly complete, or incomplete. As this is a picture of the complete excision, we have a good mesorectal fat bulb with baby butt appearances, and the incomplete as exposed muscularis. The bulk is very little and irregular. The mesorectal grade, the circumferential radial margins, lymph node yields, nerve preservation, sexual dysfunction, urinary dysfunction, recurrence, and survival are some of the markers we look at when we look at our outcomes from our surgeries, either laparoscopic or robotic. Unfortunately, robotic did not have very good randomized trials till date. There is enough published data, but these are all small data. These are comparative studies or prospective or mostly retrospective. Not many of RCTs were present in robotics. However, when we compare the main thing we do is we compare robotic, not with open, but minimally invasive laparoscopic. That's what our comparison is. We are comparing laparoscopic and robotic, and we are saying, is there a benefit? There's no point in comparing robotic with open surgeries, because we already know laparoscopic surgeries are helpful. But we did compare when we were doing laparoscopies. This is the classic trial. Every one of you is aware of the classic trial and the outcomes of the classic trial. The classic trial noted that there was significantly high positive circumferential margins in the laparoscopic arm. There's increased operating time, increased conversion to open, and the positive circumferential margins, however, did not translate to bad outcomes. They did not translate to increased local recurrence. There was no overall survival difference. There is no difference in disease-free survival. Now, the question is, does robotic have an edge here? Now, the stuff we could not do laparoscopically very well just because we are having more CRMs positive. Can we do a better job using the robot? This is an early data from Alessio Pigazzi from California. He did this trial when he did 83 patients. This is a single institute, single surgeon study. He designed the study this way just because he wanted to remove the bias of learning curve from different surgeons. He routinely mobilizes spinning flexures and the descending colons in all patients done here for LARs and APRs. What he noted was the conversion rates. The conversion rates to open in robotic group were nil. There were no conversion rates to open. Robotic group had significantly shorter length of stay. However, this could not be really demonstrated in other studies. There was a decreased sepsis and intra-abdominal abscesses in robotic group, but these were not statistically significant. He favored robotic surgery to laparoscopic surgery in his study. So what about the RCTs? There were 4 to 8 RCTs done in robotic, evaluating laparoscopic and robotic surgeries, especially robotic laparoscopic and robotic TMEs. All of these were small studies. The N was around 23 to 25 in most of these studies. So there was a meta-analysis, and this was a recent meta-analysis of 4 studies. This was published in 2014. It showed that the EBL in robotic group was significantly less. The conversion to open in these groups is again significantly less. The recovery of the bowel function is faster, but the complications were almost the same. The cost, however, is higher in the robotic group. Why are we talking about these conversions to open? Why are we worried about the conversions to open? Because the classic trial follow-up data showed those patients who were converted to open during classic trial, their overall survival rates were low. They did poorly. So the question is, can we do better robotically and decrease these conversion rates and thus increase the overall survival rates for these patients who undergo minimally invasive rectal cancer procedures? When we looked at the conversion rates, most of the conversion rates were either because of uncertainty of tumor clearance or due to the obesity noted in the patients. We know the obesity has been increasing, we have been evolving, girth-wise also, not only mentally but physically. And obesity is not only a problem with the West, the obesity is seen in India. The data says that half of the urban population is obese. What are the challenges in this obesity in rectal cancer? We all know that obese patients are difficult to operate on. It's difficult to maintain pneumolaparoscopically. The exposure is limited. The tissues tear easily and bleed, and that's why our vision and exposure becomes very limited. The momentum is bulky, just keeps on falling into your field. The small bowel keeps on coming into your field. And when you go into the pelvis, these are the pelvises that we dread. These are narrow, tunnel-like. The levators are straight up, and there is abundant presacral tissue that contributes to this narrowing. So Leela and Ashwin looked at this their data and saw if there was any advantage of doing these procedures robotically. The initial data had 44 patients, and they did low anterior resections, APRs, and intersphincteric dissections. What again they noted was that when they compared with other studies laparoscopically with similar PMIs, robotic offered very little conversion rates to open. I'm going to run a little fast here because of our time constraints. This also again is in 8 randomized controlled trials meta-analysis, which showed that again the conversion rates to open are much less. I think this is because of improved pelvic dissection technique and enhanced pelvic floor visualization. I have a video here, but I don't think I can play completely, but I'll try to skip over and see if we have time we can play the video. Where else, how else is robotic helpful? We all know that when we go into the pelvis, it's difficult to do our stapling. We have to sometimes use multiple staplers. I have known to use 3 or 4 staplers to transect the rectum deep in the pelvis. Now, we all know that any firing greater than 3 staplers has increased risk of anastomotic leak. Now, this is an area where robotic offers an advantage of not stapling using a stapling device, but transecting the rectum, placing a purse-string suture, and introducing angle and doing your anastomosis. And this is another study which again shows that there is no other significant difference except for conversion rate to open in robotic group. All other parameters are comparable to laparoscopic. Some studies, however, showed better autonomic scaling with robotic surgery. These are very small studies, and these are only comparative studies. Now, what about the learning curve? One of the main reasons why the laparoscopic resections did not catch up for rectal cancers so much is because of the very steep learning curve. Robotic here affords a faster learning curve. The learning curve around is 20 to 25 cases. Surgeons who are doing it open surgery, their technique translates into robotic surgery really easily rather than laparoscopic. So there's not that big a paradigm shift for the surgeons to adapt. And I think robotic acts as a bridge from open surgery to a minimally invasive surgery. What are the disadvantages? We know the main disadvantages here is the cost. The cost of robotic surgery is high. The operating time is, I think, would come down as we do more cases and as the surgeons become more proficient in their technique. We still lack significant randomized controlled trials for robotic. There are two undergoing trials. One is the ECOSOC trial, which I'm a part of. The trial is coming to completion. The data is being looked at, and both of these trials, the TOLAR trial, which compares both all the three, it has three arms: open, laparoscopic, and robotic. So more attention is being paid to the TOLAR because it compares three arms. We still await these trials to come so that it can guide us definitely one way or other as to which direction we go.
Excuse me, Dr. Nalamati, you'll have to wind up in next 1 minute. Your time is over.
To conclude, adoption of robotic surgery is increasing. There's no significant benefit in performing right colectomies except for increasing your learning curve and accelerating your learning curve. Outcomes are comparable, and it shows an edge over the other surgical modalities in obese patients, in pelvic dissections, in TMEs, and we await the randomized control trials. Thank you.
Thank you, Dr. Nalamati. We move on to the next talk now. Questions, I think, we'll keep for the end if there is a question and answer session.
The next topic is on optimal treatment strategy for metastatic colorectal carcinoma, scope to include newer options. Dr. Govind Babu, Associate Professor Medical Oncology, Kidwai Memorial, Bangalore. Dr. Govind Babu.
Good morning. Let me again thank Dr. Vijayanand Reddy for asking me to be here. And my topic today is how to optimally treat metastatic colorectal cancers. So if you look at the advances that we have made over time in colorectal cancers, we for a long time had just 5-FU for us, and then we had 3 other chemotherapy agents that I've listed here, followed by the targeted agents. We had cetuximab followed by bevacizumab and panitumumab, and now we have another targeted agent, aflibercept, and you already heard a lot about regorafenib from Dr. Basadik. We must remember that most patients with metastatic colorectal have unresectable disease at the first presentation, and therefore what we are looking in these patients is to increase their overall survival as a primary treatment goal. So if you're looking at upfront resection, that's possible in about 10%. The treatment strategy here needs to be surgery, and the treatment goal is curative. Whereas if you are looking at patients who are initially unresectable, you're trying to convert them, if they're potentially resectable, into resectable, And if they're permanently unresectable, then we have option of just systemic therapy and nothing else. And again, these patients who relapse here come into the purview of the medical oncologist for tackling them with systemic therapy. So we are looking at maximizing overall survival while maintaining the quality of life. So a little bit of summary of the first-line chemotherapy in metastatic colorectal cancer. We are now dividing colorectal cancers based on the RAS mutation or wild type, and we are also looking at BRAF. So if it is a wild type or mutant type, the basic chemotherapy remains the same, but there is some evidence today to say that in those patients of BRAF mutation, maybe more intensive chemotherapy would be of benefit. The treatment choice, we need to look at just more than being the efficacy part. We need to look at the clinical presentation, the patient characteristics, which include several of them, including comorbidities, and the patient preference, their expectations, the toxicity profile, and how we are going to look at the quality of life. So the treatment decisions should take into account the patient preference as well. So the ESMO guidelines, what it says is the treatment goals influencing is based on the treatment intensity. So if you're looking at different groups that I've shown here, primary resectable, potentially resectable, symptomatic with minimal disease, and those patients who are asymptomatic. So based on them, we decide our treatment and their goals of treatment. So for the group 1, where you're looking at potentially resectable, the treatment probably is intensive, whereas for those who are asymptomatic, where you're looking at disease control with low toxicity, the treatment needs to be of low intensity. So not all patients need high intensity treatment. The other thing that we have learned over time is that there are several mutations that occur in tumor samples, and this is just to talk about the KRAS one, which you're very familiar with. Then we have the BRAF mutations. We are now looking at PI3 kinase mutations and few of the others, including HER2, which I will show you. So if you remember the old slide, I was telling about the summary of the first line treatment. We have the basic backbone of the chemotherapy, and in those patients who are RAS wild type, we have an advantage of using the EGFR targeted therapy, which prolongs survival by a median of 6 to 8 months. So when we talk about high intensity treatment, we are talking about probably doublet or triplet agents with a biological agent. And this is a study, the TRIBE, which looked at adding bevacizumab as a targeted agent, which compared FOLFIRI with FOLFOXIRI. And what this really showed was that when we use this high intensity treatment, there was an advantage in median overall survival from 25 to 31 months. So this is where we are talking about high intensity treatment, where these patients have good performance status and they can tolerate the chemotherapy better. Like I said, all patients don't need high intensity treatment. This is one study, AVEX, which looked at low intensity treatment, which had capecitabine plus bevacizumab compared to capecitabine alone. So here also we did see that there was an advantage in terms of the median overall survival, but not as much as we would see with those patients who would get intensive therapy. So we have advantage of using low intensity therapy as well as high intensity therapy, and this is where the importance of individualizing to the patient comes in. So the ESMO guidelines talks about continuum of care in patients with wild type metastatic RAS, wild type RAS in metastatic colorectal cancer. Dr. Mehboob already showed you this slide. We have 3 scenarios where we could use the chemotherapy doublet with bevacizumab, and then we could use another VEGF targeted therapy, and then we could use the EGFR antibody followed by regorafenib. And similarly, we have guidelines that are given by ESMO. What we have understood over time is that just RAS mutation, the KRAS mutation, is not enough. We are today talking about expanded RAS mutation. We are looking at KRAS, NRAS, and BRAF as well. We know that KRAS so-called wild type tumors can carry other mutations, and therefore today we are talking about the expanded RAS testing and the BRAF testing as well. So if you look at the additional mutation analysis, what it has done is it has increased the number of proportion of the patients with mutations. So this is looking at a meta-analysis of over 5,000 patients from randomized clinical trials. Like I said, for a long time we were just looking whether KRAS was wild or mutant, and initially we were looking at 58% of the patients who were KRAS wild type and 42% who were mutant. So this 58% of these patients were eligible for an anti-EGFR therapy. But what's now happened with extended RAS testing is that we have 11% who have other RAS mutations, and these again become ineligible for an EGFR targeted therapy. Therefore, this percentage of 58 decreases to 47. And then we also have patients who are BRAF mutation, about 7%. That adds on again, and that decreases this percent who are eligible for a EGFR targeted therapy from 58 to 40%. So in those patients who are RAS mutant, you don't have the option of using a EGFR targeted therapy, and therefore here we target the VEGF pathway, and that can be done by bevacizumab, aflibercept, and again the RAS mutation status is not important for the activity of regorafenib, so we have it here in third line, and the second line in those patients who are RAS mutant type. So a variety of first-line treatment options exist, as I've shown you, but it's important that we look at the patient characteristics, the tumor characteristics, and very important, the patient preference. So the patient preference is one of the important things that we need to look into. Again, this slide you've already seen the impact of tumor characteristics on treatment decisions based on the RAS mutation or RAS wild type. We have several options that I've already shown you, and we now have a distinct group of BRAF mutant, which constitutes about 5 to 7%. So let's look at some important phase 3 trials which have looked at comparing different targeted agents with chemotherapy. These are two important trials which are recently discussed at ASCO. This is the FIRE3 and the CLGB 8045 study, which had KRAS wild type patients. And here the randomization was between FOLFOX and FOLFIRI and bevacizumab and cetuximab. And if you see the key outcomes of the FIRE3 study, the overall response rates in the KRAS wild type patients, you can see that there was no great difference. If you look at the progression-free survival in the wild type patients, again there was no difference. But if you look at the overall survival, there was some difference from 25 months to 28 months in terms of the overall survival. This is the CLGB 8045 study, which again compared the chemotherapy backbone which was there by addition of cetuximab or bevacizumab, and if you look at the overall survival, there was no difference here. If you look at the overall survival in the FOLFIRI treated group, that is those patients who got FOLFIRI as a backbone, comparing cetuximab and bevacizumab, you can see that there's a median overall survival difference of almost 29 months to 33 months with a p-value of 0.28. Whereas if you look at the FOLFOX as a backbone and you compare cetuximab versus bevacizumab, the difference is about 27 months to 30 months, with again a non-significant p-value. So we need to remember that other RAS mutations also influence the response to anti-EGFR therapy, and therefore we are now looking at the KRAS which was just exon 2 earlier. Now we are looking at NRAS and the extended RAS, as I showed you, in terms of exon 2, 3, 4 and the NRAS 2, 3, 4 as well, and of course the BRAF. So looking at the overall survival in the RAS wild type population in the FIRE3 and CLGB 8045 study, if you look at the overall survival in the FIRE3 study, there is a distinct difference of 26 months to 33 months in the arm that got cetuximab as against bevacizumab, whereas in the CLGB study there was no difference in the overall survival. Again, there are other studies which looked at the KRAS mutation analysis. And this is the ABF 2107 study, which again showed that there is a difference when you're talking about the KRAS wild or the mutant type. So like I mentioned, mutations in the BRAF may play a role in disease course or the response to therapy, and we need to understand that the BRAF mutations exist here in exon 11 and 15, and they do have a role to play in the resistance of these patients to the therapy that we offer. One of the studies is CRYSTAL, which looked at BRAF mutations, and they showed that this was associated with reduced overall survival, as I've shown you here. So this could be used as a predictive marker for anti-EGFR antibody treatment, but again, this remains controversial because this is data from one study. This study called TRIBE showed that more intensive therapy may be beneficial with those patients who have BRAF mutation. So this is showing you the difference in the median overall survival when they have used triplet chemotherapy drugs with bevacizumab as against doublet, showing you that the median overall survival increased by almost 10 months when triplet drugs were used. So like I said, tumor characteristics are important consideration of the tumors for treatment selection, and I've shown you the evidence for the same. So the other different factors that are involved in the choice of treatment in metastatic colorectal cancer is the patient preference. So today we have what is known as the participatory medicine, which includes sharing the information with your patient and collaborating with the patient to make a decision of the treatment that this patient is going to give. And what this means is that it's a moment in which networking patients shift from being mere passengers to responsible drivers of the health, and in which providers encourage the value of them as full partners. But there are some barriers to this participatory medicine, and this has been listed here in one of the nice articles published in 2014, which talks about arrogance, inconvenience, poor communication skills in terms of the oncologist, lack of transparency, and poor general or health literacy with the patients. So we are talking about treating our patients. We are also interested in quality of life. So this is one study, 2101, which looked at the impact of the role of bevacizumab on quality of life. And this showed that use of bevacizumab treatment maintained quality of life and was associated with prolonged overall survival. And this quality of life was studied in the CALGB 8045, where we had bevacizumab and cetuximab as two targeted agents. And this is the global quality of life. And as you can see, the quality of life was lesser with the arm that got cetuximab, although not greatly different. But when you're talking about specific quality of life related to the skin toxicity that is associated with cetuximab, we could see that there was definite decrease of the quality of life with the cetuximab arm as long as they got the treatment. So like I said, quality of life is a key part of the treatment, and it's important for all our patients and their families. And quality of life has not only been associated with good compliance to the treatment, it's also been associated with increased survival. It can be a deciding factor when treatments have similar efficacy. And treatment that maintains the quality of life, like I said, enable long-term treatment and compliance from the patient, and this could help in maximizing the overall survival. Having more treatments has increased complexity for treatment decision-making for us and for the patients. So we have chemotherapy options of triplets, doublets, a single agent, and in the second line, we could have doublet chemotherapy or irinotecan. In the third line, again, doublets or irinotecan. Similarly, we have several options in targeted therapy. As I mentioned, we have VEGF targeting with bevacizumab or aflibercept, and now we have regorafenib as well, and EGFR inhibitor, the main drug that we have is cetuximab. So we are spoiled for choices here today. So what we need to do is have evidence-based treatment planning that provides means to ensure the optimal use of available agents for the treatment of unresectable metastatic colorectal cancer. Understanding PFS and OS data for different treatment options can support the treatment planning that we do for our patients. So what is the available evidence for biological agents in first-line treatment after all the evidence I've shown you? Is that there is consistent overall and PFS survival when bevacizumab is used in first line, regardless of the chemotherapy partner. And this is data from over 3,730 patients in phase 3 data from 8 different studies, whether it was oxaliplatin based or irinotecan based or the triplet regime. And so we have evidence-based medicine that forms the basis for decision making, and this is the evidence I've shown you. 4 observational studies also confirm the survival benefits with first-line bevacizumab, and this data is from over 5,000 patients. Phase 3 studies also show the efficacy of targeting the VEGF pathway with bevacizumab in KRAS wild type. So this is the data from several studies for you.
Dr. Govind Babu, time is up. Right.
Okay, this is some data from EGFR inhibition, and this is the use of the new monoclonal antibody panitumumab, and again this is in the KRAS wild type. Again, this shows that this probably is a slightly better agent as compared to bevacizumab in first line. I think this is evidence in second line, again to show you that there is good evidence to target the VEGF pathway. This is one study where the new monoclonal antibody ramucirumab has been approved in second line. This was approved just this year in January. In the third line again we have biologicals that could be of use. You already heard about regorafenib, so I'll rush over these slides. So we now have another drug that could be used, that is regorafenib. You've seen the slide about the disease control in these patients. The 2 different trials, CORRECT and CONQUER, and this is the ESMO and NCCN guidelines as to where this drug fits in. So to summarize, we have several agents that can be used, the chemotherapy and the targeted agents, and a new entrant of regorafenib, which is a multi-tyrosine kinase inhibitor. This is all the summary of all the evidence that we have of the 4 so-called targeted agents that we have for colorectal cancer today. With that, I think I will stop. Thank you.
Thank you. Please join us. We'll take the
Translational Research, Department of Radiation Oncology, University of Pennsylvania. He'll be talking on practice-changing innovations in GI cancers in the last 2 years.
So while the presentation loads, I would say that this was a difficult task. I mean, first, there's lots of things that are happening in oncology, and to really distill what is the most important that is happening in GI oncology is not easy. I consulted with many of my colleagues, medical oncologists, radiation oncologists, surgeons, and it was actually turned out to be a very nice task, and that I enjoyed tremendously. And I'll talk about what sort of the consensus was about the most influential things. It's not really in the last 2 years, maybe more extended into the last 3 to 4 years, but nevertheless, what we think are the really important things, or examples for important things. In the surgical field, minimally invasive surgery in most diseases seems to be a trend that is posed to make a difference in some sites, not in all sites, but in some of the GI sites. And I'll give an example of what happened in esophageal cancer with minimally invasive surgery. The other big thing that our chair at Penn, Jeff Drabin, thought is the most important thing that happened is really the advances in perioperative care. And what this does, it allows patients to survive major surgery. and it extends our ability to perform complex operations, vascular resections for hepatobiliary cancer and pancreatic cancers. So with minimally invasive surgery, the concerns, obviously, you've heard a lot about that, is the ability to obtain adequate margins, the extent of lymphadenectomy, peritoneum, and the possibility that this would actually spread intra-abdominal cancer, extraction of these large specimens via port and port recurrences, the cost of it, and then the most important thing is the inadequate training and the steep learning curve that's been described many times. The benefits are faster incision healing and faster start of chemoradiotherapy or chemotherapy alone, and it's less immunosuppressive. So in theory, it could be better than just open surgery, and it improves quality of life. The rate of adoption of minimally invasive cancer in the United States is increasing, and it's increasing actually quite fast. And the short-term outcomes are superior. The long-term outcomes seem to be equivalent, and we're just now starting to get some idea about the long-term outcome. And the major barrier is still training and the steep learning curve. So this is a publication from the Lancet that compared minimally invasive esophagectomy versus open esophagectomy. It was a few years ago, I think 2-3 years ago. And I point your attention to the arrows. They showed in this randomized Dutch trial that they reduced pulmonary complications. Within the first 2 weeks, they reduced pulmonary infections in the hospital. They reduced hospital stay. They reduced pain. And they improved the ERTC C30 quality of life. They also showed equivalence of the total lymph nodes that were retrieved, equivalence in the RZO resection rate, equivalence in the T stage, and equivalence in the mortality rate. But again, improvement in operative time, an increase operative time with the minimally invasive surgery, but reduced blood loss, again, reduced pain after surgery, and less, interestingly, vocal cord paralysis. Now, if you're asking what this does on the long term, this was just recently published, I think a few months ago. And this is a phase 2 trial from ECOG. And what they have shown is that the minimally invasive esophagectomy is feasible and safe. There's low perioperative morbidity and mortality and good oncological outcomes. You can see the grade 3 adverse events, anastomotic leak, 8.6%, the acute respiratory distress syndrome, 5.7%, pneumonitis, 3.8%. And the median follow-up was 36 months. So that starts to be pretty substantial in esophageal cancer. And with that, the 3-year overall survival is 60%, and the local regional recurrence is only 7%. These seem to be very good results, so it's promising. The second topic is optimization of perioperative care. And these are things that I'm sure have been implemented in surgical departments here, but have been implemented in many places and result in very big difference. The important thing to take home, the take-home message is that the difference that this better perioperative care makes in these patients is fairly similar in magnitude to gains that are made by anti-cancer therapies. And I'll show you a few examples of that. So it's nothing to be taken lightly. Some of these improvements include improved management of comorbidities, diabetes, obesity, cardiac morbidities, smoke cessation, improvement in nutritional status prior to surgery, prophylactic antithrombotic therapy, physical rehabilitation before you go for surgery, reducing the immunological impact with the provisions of steroids, and implementation of these programs that are called enhanced recovery after surgery, the ERAS program. And this is just an example of implementation of an ERAS program. There are very, very detailed instructions of how to treat these patients in the perioperative period, and this had actually reduced the rates of mortality from major cancers, and you can see this data in the New England Journal of Medicine in 2011. Esophagectomy you could see that there was a reduction of 2 or 3%. In pancreatectomy, there was a reduction of 2 or 3% of perioperative mortality, and it's now down to 7, 8%. These are important reductions. In the field of systemic therapy and medical oncology, I think the paradigm of targeted therapies and in conjunction with personalized medicine, where you actually do genetic profiling of tumors, has resulted in the last few years in a few major advances. Not so much in colorectal cancer. I mean, there have been obviously advances in colorectal cancer, but what I want to highlight today is the HER2 story and the TOGA trial. You have heard about this, but look at the magnitude of difference in median survival. It's quite substantial. I mean, we're not talking about days, we're talking about substantial differences and long-term differences in patients who have HER2 positivity. In pancreatic neuroendocrine tumors, look at the differences with sunitinib. Very substantial differences. This is a publication from the New England Journal of Medicine in 2011 in overall survival. So the hazard ratios was essentially cut in half, 0.4, 60% reduction in mortality. So we still need to continue and look for those mutations that are really driver mutations, but from time to time in different diseases we would hit on some of these driving mutations, and when we have a drug for that, the differences could be very substantial. The problem is that in many other settings we find mutations, but they're probably not very important mutations, so they do make a difference. So for instance, the RAF mutation, it's been some advance, but it's a relatively small advance. Here is another example of everolimus for pancreatic neuroendocrine tumor, another publication that shows a very, very large differences. Again, the hazard ratio is of the order of 0.35, 0.34, a 70%, 65% reduction in mortality in this disease with this. These are very substantial differences. You can drive really a truck between these survival curves. They spread apart so nicely. In radiotherapy, there have been some advances. I think that the most substantial advance, and this is not new, it happened over a decade or more, is the advent of stereotactic body radiotherapy for many sites, not just for liver tumors, but in the GI, it's mostly for liver tumors. That's where evidence was generated. We talked previously about the rationale for liver tumors, but really what this does, it allows physicians and patients to have a treatment options that is almost devoid of side effects. If you look at the grade 3 toxicities in SBRT trials or series, it's in the single digits. And these patients receive 3 or 1 or 5 fractions, and they go back to the medical oncologist for systemic therapy within a week or 2. When the morbidity of therapy is so low, it really changes the whole pattern of practice of what you can do with these patients. If the comparator is surgery, where you would need to take a month out of therapy, an interruption in therapy, in order to perform surgery on a liver metastasis, that is disruptive. And when you consider morbidity and mortality in surgery, then you can start realizing what big of a difference SBRT makes. And in the field of liver metastasis, I didn't have much time to highlight this trial, but I think it is an important. It results in stable, durable local control. And I showed these slides before, but I want to re-emphasize this. I think that it's important to understand that stereotactic body radiotherapy performs very, very well compared to other modalities we have to treat liver metastasis. So for instance, to RFA, we talked about that. It's pretty equivalent, and it's better for the larger liver metastasis. with less grade 3 toxicity. In our series at Michigan, 0.9% grade 3 toxicity. Lastly, I want to spend a few minutes on advances in multidisciplinary management. And this is a trial that I conducted through SWAG. It was a phase 2 trial, 0809. It's not important because of the very sort of fancy chemotherapy or radiotherapy that we have used, because it was not fancy. But the importance of this is that it really establishes a new and more data-driven baseline or for practice. It really provides very substantial rationale and background for what we sometimes recommend to our patients, but now you actually have some real data to back it up. And this is the first adjuvant trial in gallbladder external extrahepatic cholangiocarcinoma ever conducted. And you can see we accrued 79 patients to this trial. And the outcomes were very good. Most of these patients were patients with extrahepatic cholangiocarcinoma, but about a third were patients with gallbladder cancer. The 2-year survival was 65%, and the 2-year local control was 89%. And this exceeded our expectations. It met the pre-trial criteria that we set for what would be promising. This was a trial for patients with extrahepatic cholangiocarcinoma, gallbladder cancer or bile duct, but not for ampullary cancer. Patients could have R1 resection, T2, T3, T4, or node positive. So essentially the only patients we did not take into the trial were T1 and 0. Everybody else was eligible for this adjuvant trial. No distant metastases, good performance status, and adequate organ function for chemotherapy. The treatment was fairly simple, 12 weeks of gemcitabine and capecitabine, followed by chemoradiotherapy, and the chemoradiotherapy could be delivered with 3D or with intensity modulated radiotherapy. The dose was between 54 and 59.4, depending on whether you received it with 3D or IMRT, and depending on whether the margins were positive or negative. There was mandatory assessment of motion due to breathing. We had a very rigorous quality assurance in this trial. We reviewed centrally the surgery, pathology, radiation therapy plans, and one slide from every block of a specimen had to be submitted with a copy of the pathology report so that we could verify the diagnosis, the site of origin, the pathological stage, verify the adequacy, that is the radicality of the resection, and confirm R0 versus R1. I have to say that this actually excluded about 20% of the 108 patients that we accrued to this trial. We ended up with 79, so this was a very important part of the trial. All the radiotherapy plans were reviewed prior to treatment and reviewed at the end of treatment, and there was guidance that was provided online through the QARC site on how to contour structures for radiotherapy and plans that radiation oncologists could look at so that they can come up with plans that satisfies the protocol requirements. And as I said, the 2-year survival rates were 65%, very similar between R0 and R1. The median overall survival was 35%. The 2-year local control rate was 90% almost, and it was slightly worse for R1 resection, but not bad, 84%. And the grade 3/4 toxicity was roughly what you'd expect with this regimen. Nothing that would stop you from using this regimen in clinical practice. These are the curves, and we also learned very interesting things about a pattern of recurrence, mostly that the pattern of relapse between gallbladder cancer and extrahepatic cholangiocarcinoma are not that different. They trend differently. There's a trend for more distant relapses with gallbladder and more local relapses with extrahepatic cholangiocarcinoma, but there were no significant differences, statistically significant differences in those trends. So, as I said, that could be in the absence of really phase 3 data, and the phase 3 data is currently being planned. It's going to be sort of an intergroup trial. But in the absence of a phase 3 data, this regimen is a practical regimen. It's very well supported by the data, And I think that it pretty much is the new standard until we would have this phase 3 data that would emerge in a few years. Lastly, not much had happened in immunotherapy in GI, but I think that this is the future, and although it's not exactly, I cannot point to you to very important studies that are practice changing as of yet in GI oncology. I just wanted to draw attention to a few things. And as you know, there's a lot of excitement about immunotherapy, and I'm also excited about the recent results. There's the development of therapeutic cancer vaccines, or the indirect stimulation of host immune systems by targeting tumor-evasive mechanisms with drugs like anti-PD-1, anti-PD-L1, and anti-CTLA-4. And all of these, we are currently engaged in clinical trials, for instance, at the University of Pennsylvania, but in other institutions, alone or in combination with radiotherapy. We want to use radiotherapy as a vaccine to expose the immune system to antigens and to allow cells to actually penetrate into these cancers. And the last approach is the adaptive transfer of autolog immune cells, and this is just a proof of principle again. This is from Rosenberg group at the NCI. It's a publication in Science last year. And what they have done, they've taken the tumor, they've sequenced it, they identified some mutations, they then removed T lymphocytes and sensitized them against those particular sequences, injected them back. And what they show in this publication is that when they give them back, they obtain responses in patients with metastatic, this was a cholangiocarcinoma. Patients did very well for something like, I think, a year, 13 months, and when they progressed again, they repeated it. Only that this time they didn't give them a T lymphocyte suspensions of 25% specific cells, but a 95% specific cells, and they obtain a second remission when they've progressed. So I think this is proof of principle, and everybody should be looking to this thing coming, I think, in the next few years to our practices. And I think I'll stop here, a little bit ahead of time.
Thank you, Professor Edgar. Could you please join us here on the dais? We have some time and we could take probably 2 or 3 questions. Can we just call Dr. Mehboob also to be on stage, please? Dr. Mehboob Basade.
Any questions to any of the speakers? You're welcome. I'll start my question. If no, nobody,
Yeah, my question to Dr. Edgar. Sir, in your SWG phase 2 trial, which you showed GEM-CAP versus followed by concurrent chemo radio, why did you exclude the ampullary, or is it the whole group or the resectable group which has been excluded in this trial?
I'm sorry, I didn't hear you very well.
The audio on the stage is not at all clear. We are not able to listen to what the audience is asking.
AV team, can you kindly increase the volume of the stand mics, please? Thank you.
Can I repeat? Am I audible, sir? Yes. Sir, I just want to enumerate that in your SWG phase 2 trial, which you have shown in the GI malignancy, the ampullary cancers were excluded in this study. Was it the resectable group or per se the whole population, and why so?
No, this was an adjuvant trial. It was an adjuvant trial. All patients had R1 or R0 resection.
Post-op.
Yeah. Okay. So there were no unresectable patients there.
So why post-op ampullary R1 were excluded from this trial?
Yeah, it's for historical reasons. For some reason, we don't usually include ampullary cancers in the extrahepatic cholangiocarcinoma group. I don't know that there's a really rigorous rationale for that, but that's a tradition.
Any other question from the floor?
I have a question to Dr. Surya. You mentioned that total mesorectal excision by robotic is better than laparoscopic? Do you think it is purely to do with technique of this competence of the surgeon, or you think the robotics really makes a difference?
I do think the robotics really makes a difference. All the studies we cited all of them are very experienced and accomplished laparoscopic surgeons, and most of them I know personally. The robotics for TME I think would be a game changer. The only inhibition for us would be the cost. I don't see the cost being contained in future, but if there is a parallel systems developed or more economical systems developed, I think it will be well accepted. So the simple answer is yes, it's better with robotics. I could not show you the video, but if I do, you will also see why so, especially in these obese patients with BMIs more than 30, very narrow male pelvises is still feasible. I think that's the only reason why the conversion rates to open are so less when we do robotics, and these are statistically significant.
The other question I have is, if suppose you have a right colon malignancy patient operable, and you have a laparoscopic surgeon, a robotic surgeon, and an open surgeon, who decides and tells the patient that this is the right way to go?
I tell the patient, I give them a full disclosure before the surgery. I tell them that there is no significant difference between laparoscopic and robotic right hemicolectomies. In my personal opinion, and also in my personal practice, I don't routinely offer robotic right hemicolectomies. I have done about 140 left and low anteriors and APRs, but only 8 right hemicolectomies. So I do it very selectively in very obese patients where I think the mesentery will be too heavy to handle even laparoscopic. I do think the benefits are similar, the costs are very high, so I don't offer robotic right hemicolectomies routinely.
Any other questions from the audience to any of the speakers?
I think we should be able to call it off.
So we conclude the session here. Thank you.
Thank you very much, Chairpersons. Ladies and gentlemen, we move on to the last session of ACC CCI 2015. And before I invite the panelists, followed by the moderator on the dais, may I bring to the kind attention of the august audience that all of you have been provided with a voting pad. The moment our moderator flashes the question for the vote, there will be 10 seconds. The timer would be on the screen. So once the timer starts, please exercise your right to choose and vote what is your option. With these few words for the next 40 minutes, may I invite members of the expert panel, Professor Edgar Ben Joseph from Pennsylvania, Philadelphia, Professor T. Subramanyeshwar Rao, Director and Head, Department of Surgical Oncology at the Basavathrakam Indo-American Cancer Hospital and Research Institute, Hyderabad, Telangana, Dr. Prasenjit Chatterjee, Consultant Medical Oncologist, Apollo Clinicals Cancer Hospital from Kolkata, West Bengal, Dr. Chinnababu Sunkaballi, Senior Consultant Surgical Oncologist at the Apollo Cancer Hospitals in Hyderabad, Dr. Vamsi Krishna, Senior Consultant Medical Oncologist at the Apollo Cancer Hospital in Hyderabad, and Dr. Bhavna Sirohi, Head of Medical Oncology at Mazumdar Shah Cancer Center from Bengaluru. Ladies and gentlemen, leading the discussion is a moderator, Dr. Sendil J. Rajappa, Senior Consultant Medical Oncologist at the Basavathrakam Indo-American Cancer Hospital and Research Institute for the next 40 minutes. Over to Dr. Rajappa and his team of panelists. Thank you. And the delegates are kindly requested to kindly leave the voting pads once the voting process is done at the end of panel discussion and hand it over to the AP crew. Dr. Rajappa, please. Thank you.
Can we have the mic? Is that on? Right. So, thank you again for calling me here to do this panel discussion. As we will have those voting pads, so please feel free to vote. What I want to tell you is that all of these cases have clinical situations which don't really have high quality evidence that you've been talking since morning. Okay? We're not having level 1 evidence for most of the situations that I will discuss today. And the reason why you have a star panel sitting up here is that the audience really want to know what the stars would do when a movie star like this would come to you. Okay? So the star on the right extreme is already nodding his head. Right. So that's what it is. So all of you feel free to vote. So here is a 45-year-old movie star with bleeding per rectum of 15 days. On digital rectal examination, he has a low rectal growth. Colonoscopy shows an ulcerative low rectal growth. Biopsy is a well-differentiated adenocarcinoma. The rest of the colon is normal on the colonoscopy. The CT scan shows a rectal growth extending up to the serosa with perirectal lymph nodes, the largest of them being 1.2 centimeter. The chest X-ray and his blood investigations are normal. Okay? So anything else that the audience would, so we'll have the audience poll and then we will ask the experts on the stage what they would do. So audience poll, anything else that you would like to do for loco-regional assessment? This is a very regular run-of-the-mill situation. You can start voting now. MRI, EUS, both, PET CT, or you're very happy with the CT scan, you want to get on with the next step. Poll results. Okay, let the poll results on. So let me start with the surgeons. What would you do in a situation like this? Dr. Chinnababu, what is your protocol for patients with at least clinically early rectal cancer?
You mean to say further workup?
Yes, for local regional disease. Are you happy with what has been done?
Probably I would consider an endoscopic ultrasound to reassess the T stage, and based upon the location of the anal verge, I would even consider an MRI.
So for you it is CT scan with contrast and an EUS, is that correct? Dr. Subrameshwara, what would be your preference?
I would be choosing the fifth option. Basically, and would want to do an examination under anesthesia. I would prefer that over any further evaluation. If a CT was not done, I would have preferred an MR. If I was given a choice of the first imaging tool, I would have preferred an MR over CT. But now that CT was already done, I don't want this patient to spend anything more. Yeah, it has already reached the serosa. It's unlikely that I would get too much more information from anything else that I would be doing on this patient.
Most of our audience seems to be wanting both MR and EUS.
Yeah.
All of them.
That is the difference between a star and
superstar. Star and superstar.
Yeah, I think I second.
What would be your protocol in your place?
So we already know that he has locally advanced pelvic disease, so I think if I were to get additional studies, I would actually get a PET to see if we can stage him better systemically. PET discovers about 10 to 15% of metastatic disease that is otherwise not discoverable by any other means. So you could get a PET, and that's probably what we would have done. Then the question is a surgical question, and that a lot depends on the digital rectal exam. If you are sure that you can actually remove this tumor, and you already had made up your mind if this is going to be a sphincter preserving or not a sphincter preserving surgery, then I think you don't really need to, but if you have any additional pelvic staging, but if you have any questions about what it's going to be, you could do the MRI either now or later after the chemoradiotherapy to try and make that decision.
I thought you wanted to say something?
I just wanted to second the surgeon. I think we should not waste the resources given in the setting.
Don't waste
resources.
Once
the CT scan has been done, I think we can do an assessment where the serosa is already bridged.
I think we've got a very conservative group sitting here, so we won't waste any more resources and time. So this is what results. Okay, so I'm not seeing it on my screen. So again, somebody wants to have an MRI. Some don't want any more assessment. Some want. Okay, so we've got a difference of opinion there. Again, let's start with the surgeons. One of you. Is there any relevance to reassessing?
Fifth option once again.
Okay, straight to the OR.
Yeah.
Peritoneal examination and OR.
Unless I have a clinical intuition and impression that the disease has progressed during your great treatment.
My great treatments. Okay. Right. So you get them straight to the OR. So anybody else has a difference of opinion there? Yes, Bob.
So this patient has actually had 6 weeks of chemo rad and then you have a 6-week gap, so 12 weeks. So I would definitely restage the patient with the modality.
Okay, so let me ask the question, how many people during your chemo radiotherapy would have progressed out of 100? Because then you're putting the surgeons on the dock, you're saying that I want to restage. Are you talking about systemic staging, local staging?
So you would actually stage both because some patients do develop liver metastasis.
What percentage in your experience
so
at
about
Tata
10%
Hospital?
would 10
That's
to 20%.
a big number.
Yes, it's a big number. And also the other thing, going back the treatment, there are 2 randomized trials comparing short course versus long course.
No, we are going to conventional long course.
So restaging is a must, I think, after because the patient has been off treatment for 12 weeks, which is good systemic treatment. Only capecitabine with radiotherapy has been given.
So since you said capecitabine FDG PET, MR, EUS or CT scan were good enough to predict what the response was. It's ultimately the surgeon and the pathologist who will dictate what response your patient has. Each and every technique has its own pitfalls and hence there is nothing called a standard after you do chemoradiotherapy. So we have our film star here who's had a complete clinical response, biopsied, that site is also negative. So what would you want to do? So the MR is showing minimal rectal thumb. Okay, brilliant. So usually I send it off to the surgeon, so I'm going to send it to Chinnababu now to decide what you want to do. Because you're in Jubilee Hills, you're likely to see more film stars. So, you
Thanks for the compliment, but my choice would be none of these. I mean, I would, since we are given a neoadjuvant chemo RT, I would like to reassess the patient for feasibility of a low anterior resection rather than an API because sphincter preservation is very much possible.
It's a lower 1/3 growth, so you would still have a possibility of doing
still
that.
I would look for
Okay, assuming for a moment that you can't do.
No, I would, if I can get a
Okay, assuming for a moment that you can't do a low anterior resection because
basically it's APR/yeah.
specific clinical situation. So what would be your problems in saying no, you should not be doing this at all? So for a moment, assuming that he is ready to come every week for you to shove your finger up his ass, would you still?
I'm not ready to do that even if
even if he wants standard of care. Dr. Joseph, how frequently do you come across a situation like this and what do you do?
I couldn't give you an exact number, but maybe 2 in 10 would
okay.
Give,
so that I not randomized. This is very good data. 72% had sustained CR at 4 years. Organ preservation was 77% versus 0 because the 0, all of them had surgery. Okay? So I think we have to keep our minds open. This question has raised and that's exactly why I wanted to put it there. But what I want to tell you also is that a reputed organization of senior oncologists also says that it can be done. And in fact, you will also see that if a patient is not fit for surgery, you obviously will leave them alone. So this is 2014 ESMO guideline.
But if I may again interrupt, but that was not a neoadjuvant protocol what we
No, this is after
early rectal
neoadjuvant.
cancer
This is after
group.
neoadjuvant. This is after neoadjuvant. Yes. So let's leave that at that point and not waste any more time on it. What I want to try and say is that this is something that you'll keep talking to your patients. You have to be very selective. The follow-up is very rigorous and so on and so forth. 5 years down the lane, we may be sitting in the same hall and saying that why the hell did you have to operate? Okay, so that's what oncology is all about, change is all about. Okay, so he underwent APR.
As well. And now we have data also to show that, in rectal cancer, there is some disease-free survival benefit if you give adjuvant therapy.
Okay, let's say
the debate is where you have PAC-CR, not where you have tumor.
Yes, we are extrapolating this from colon. Let's take T3N0 colon cancer. What would you do here? Here you're saying you would no high-risk features. Yes, I know that you will say this is neoadjuvant treatment, so we'll have to do this and that. But having said that, T3N0 you will say and its role has not been well defined. But it's recommended for all patients with stage 2-3 after neoadjuvant treatment, regardless of surgical pathology. Although conclusive data is lacking, FOLFOX, KPOX is recommended, FLOX, CAPE, 5FU are alternatives. Rather sad that we have to follow these guidelines which are extrapolated from colon, but you do something very different in colon and you want to do this in rectum. Okay? So we leave it at that point. So for students, you have to quote a guideline. So you will say that if it's rectal cancer, we are extrapolating, this is what NCCN says, and this is what we do. Okay, but it continues to be a problem that we face when we treat patients, when we face them, that what do you do after neoadjuvant chemoradiotherapy is not well defined at all. Anybody wants to have the last word on that? No. Agree. Very good. So, summary of the first case, we are not yet done, is MRI EUS for surgical staging, depending on what it is. No standard evaluation techniques post-chemoradiotherapy. Selected patients with CR may be offered wait and watch with strict surveillance. It's not standard of care, but the ESMO seems to think that some patients can be offered that. There is no standard adjuvant chemotherapy approach after chemoradiotherapy and surgery. All patients to be treated, query. So that's where we will leave this. We'll go on to this case. This is actually Dr. Joseph's case. He was kind enough to send one of his patients. So I will discuss the first half of this and then quickly sum up that case. So 45-year-old lady presented after an open cholecystectomy done for abdominal pain and dyspepsia. Histopathology showed an adenocarcinoma. No details regarding anything else. So the block was reviewed in the central hospital in Penn Medicine. Moderately differentiated adenocarcinoma up to muscularis. No lymphovascular invasion. No lymph node tissue, margins cannot be commented upon. Okay, so what do you do, Chinnababu, in a situation like this? This is a very common situation that we see. No voting, please, don't bother, push the next line. So we are asking, what do
T1B?
Yes, so what do you do in a situation like this? Okay. So this is incomplete, isn't it?
Yeah, we would restage before.
So how do you really do? Here is a patient, open cholecystectomy, they come to you. So when would you do that restaging? What would you use for restaging?
No, as you rightly mentioned, I would review the pathology specimen and the stage is now T1B. So I would like to rule out this metastatic disease by doing a CT scan.
How long after? Immediately, sometime later? Because
should wait for at least 3 weeks.
Okay, let's say this patient has had inadequate surgery, isn't it? What would you say is adequate surgery for gallbladder cancer?
For any lesion T1B and above, the minimum surgery is a radical cholecystectomy.
Which would consist of what?
So which includes complete removal of the gallbladder and segment 4B and segment 5 resection and periportal lymph node dissection.
Excellent, brilliant. So this
no,
patient...
I disagree. Yes, in Tata, I think segment, there is no clear-cut this thing that you have to do segment 4B, 5
okay,
resection. You remove
carcinoma. Okay. That shouldn't have any difference of opinion there. Pancreatic neuroendocrine tumor, 31-year-old lady, absolutely asymptomatic. Any thoughts? Okay.
So chromogranin per se is not a part of a staging. I mean, it's not.
No. We are still at the diagnosis stage. We haven't done any
What
staging.
I'm trying to say is chromogranin alone, absence or positive, is not significant.
Absolutely correct. So Vamshi wants to say that the chromogranin alone is not diagnostic of a neuroendocrine tumor. Okay. So then this patient had an endoscopic ultrasound, an MRI and a PET CT. Okay, that's what the endoscopic ultrasound says. And then she had a biopsy from the pancreatic tail mass. Okay. And this is what the MR showed. Okay, we are slightly, I think you have to move fast with me, right? Next one, please, on yours. Yes. So it says that there is a 2.8 centimeter mass lesion in the body and tail of pancreas to correlate with biopsy and biochemical parameters, 2 nodular liver segments, to 3.6, 1.3, most likely metastatic. Right? And that's what the FDG PET shows, correct? So L-defined mass, SUV is 4.7, the liver is SUV 6.7. So if you really value SUVs, okay? So that's what the situation is. So what would you do, Dr. Bhuvanesh Rao, in a situation like this? This is, yes, so that is what the biopsy report shows. Features are suggestive of adenocarcinoma. The liver FNAC is also showing adenocarcinoma. So just like Chinnababu said, this is clearly a case of stage 4 pancreatic adenocarcinoma, well-preserved 31-year-old lady. What would be your approach in this situation? Would you pack it off to me or?
Yeah, I would not operate on this patient.
You would not operate on this patient. Anybody else has a difference of opinion?
So, yes,
Yes,
the patient
Babu.
should come to you, but
Yes,
there is,
she did.
she's 31 years old,
Yes.
tiny liver mets, and there is data from Professor Buchler's group about if the patient responds or remains stable to go for metastectomy and removal of the primary.
Anybody still has a doubt with regard to the diagnosis? Because Dr. Pratap Reddy, who is sitting here, in fact, this case is primarily being discussed because he is so...
You have done a true cut biopsy both from the pancreas and the liver?
Cell block. Cell block on the liver. Yeah, it's not a true cut biopsy because that's difficult on EUS. Okay, so he is a very, very astute clinician, and he saw this patient first, and his first thoughts were that this is not adenocarcinoma, even if the pathologist says. Okay, he says, or rather he thought, that this was a neuroendocrine carcinoma because age, the clinical setting, absolutely well-preserved patient. This is not the presentation of a pancreatic carcinoma. Okay, so we also did get a Dotanox scan done. Okay, the Dotanox scan clearly shows that this is not a neuroendocrine carcinoma. So that doubt has been clear. Okay, so between us, yes, you know, when we discussed this in our tumor board and everybody had this thought that, yes, are we going wrong with this diagnosis in a 31-year-old? So that's where it stands. So this is what we did. So she went on to get 3 cycles of Folfirinox, 31-year-old. 15 to 20% response in the primary and liver. What next, Bhavna?
So, you know, I would go for consider surgery as an option in discussion with the surgical oncologist, because if she's responded, and I think we should give her the best chance of cure, and there's enough data to back that up now. Not randomized data, but enough evidence to back that up.
Dr. Bhuvanesh Rao.
I would still give her a chance because in such situation you cannot go forward with anything else. You must give a chance to the patient and not to the tumor. I would go ahead and resect both.
So you have said this in front of 200 people, right? So I
patient is
will
going to
send
come
this
to me.
patient to you in 1 week. Dr. Pratap Reddy is sitting here. Yes. So,
Not a problem.
Yeah,
Not a problem.
yeah, I am really a proponent that this patient should undergo surgery.
Can I
Okay.
offer?
Yes, Vamshi.
Yeah. She has had 15 to 20% response. You can do a surgery even after 6 cycles. There is no requirement that you has to do a surgery right now.
Okay, if the liver met disappears.
If a liver met reduces even more, then after 6 cycles or 8 cycles, you can consider the surgery. It's one more option.
I would be much more comfortable to see or feel the liver now and then resect.
Correct, because it's already 3 centimeter was what it was. It's come down by another 20 centimeters, so it's 20%, so it's about 2.5 now. So we don't want it to get lost. Not that it will, before the patient gets lost.
You would also have a better handle on the histopathology.
Correct, so that at least we will prove him right or wrong. Correct. Right? I still hope she's got a pancreatic neuroendocrine tumor, because all of us should wish well for the patients, not wish well for ourselves. Okay, so there's still, that option number 4, which will say, I doubt this diagnosis, let's start all over again, is what we said. And that's how we got this Dotanox scan. And that's the Dotanox scan report saying that there's no evidence of a somatostatin receptor abnormality. Very good. So I think we will not go to the next case because we will leave it incomplete. So thank you all panelists for being really a sport. Okay? And really trying to navigate through situations which don't have good clinical evidence. I think that's the interest of clinical medicine, not looking at, yes, Dr. Pratap Reddy, as you're coming to the mic, not really looking at NCC and ESMO and saying that this is what should be done or not. Yes,
I based on my assessment in this case that it should go for surgery for another reason also.
Yes, please.
There's no way cytologically to differentiate a cyst adenocarcinoma pancreas with MET versus adenocarcinoma.
So yes,
there is enough evidence about with cell blocks. On cell block, if you have adenocarcinoma, very unlikely that it will change. That's what pathologists tell me.
Right. So I think it's going to be both a diagnostic and a potentially therapeutic surgery. So we will subject her to surgery. Thanks. So we've got so many people testifying that we have to do surgery. Thank you so much for that. Thank you so much to all panel, and I'll hand it over back to...
Thank you very much, Dr. Rajappa and the members of the expert panel. Ladies and gentlemen, please stay back. May I now invite the organizing chairman, Professor Vijayan Reddy, to kindly propose the vote of thanks before we formally draw the curtains of ACC CCI 2015.
And before I get off, I really want to congratulate Dr. Vijayan Reddy on behalf of all of you sitting here for putting up such a brilliant show. I think he deserves really a loud applause. Thank you so much.
Thank you, Senthil. Thanks and entire team for being with us. And the success of the conference is basically judged on the number of audience that were sitting in the hall. First people are the first to come on the top to thank somebody is the audience for the trust and faith that they have in this meeting for the last 12 years, and they have been regularly coming for this meeting. And I'm really, really thrilled and happy to see such wonderful response from across the country and neighboring countries. Apart from that, the faculty coming across the globe, this meeting, I sincerely thank them for being with us, and with not much of a, normally when you ask for a meeting, the speakers to come on, they ask for too many things. They ask for business class tickets, blah, 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 this and that. But let me honestly tell you, they have been so nice to come on their own. Majority of them, they have come on their own and with minimal support what we could do. And I sincerely appreciate and thank them from bottom of my heart for being here all through crossing so many countries. Next in line, if I need to thank one single individual of all to make this conference so successful, is one single person, none other than Dr. Prabhakar Tripraneni. Thank you very, very much, Dr. Prabhakar, and you have been the backbone, you have been the scientific chairman of this meeting, and you are the person who could make this conference of such a big magnitude and such big good content in the conference. If I need to mention a second person to help me to make this conference so big, so without any difficulties, with so ease, is my secretary, Mr. Madhu Babu. He's a one-man army, and people ask me, do you need an event manager? I always say I don't need. This guy is an individual who can do wonders, and hats off to that guy. In spite of his father's ill health, his father had a hemorrhage in the brain, and he fell in the bathroom, and he was admitted in a hospice center. In spite of that, he was working throughout the night and helped me to get through. And my entire team, my colleagues in my hospital have been wonderful, especially my students, to name each one of them, Shilpa, Nandita, Madhuri, Mudassar, Viraj. All these guys have been really, really very, very helpful to put together this wonderful event. My team members, Dr. Vinita Reddy, Dr. Sajal Kakkar, Prashant, were always with me throughout these last 3-4 months. I left my clinic, and my dear colleagues have helped me a lot to take it forward. Dr. Kaushik Bhattacharya, Dr. Bandari, Juluri, and Chinubabu, Dr. Prasad, Dr. Srinivas Chakravarti, my colleagues have always been with me to help this conference go in such a good way. Without, ultimately bottom line is that we need money. And the pharmaceutical companies have been with us the last 12 years. Whenever we do this Cancer CI meeting, they always came out with a big, big support. Without naming one or two companies, I immensely thank each one of them to be with us and support throughout to get this conference of such big magnitude. So thank you very, very much, and I would be failing in my duty if I don't thank my wife. She has been a wonderful woman for bearing me the last 3-4 months, and she took so much of time to look at each and every aspect of the lunch and dinner and the snacks what we gone through. She was with the chef and talking to them all through and make sure that all of us are given proper food and a tasty food. Thank you very much, and God bless you all, and thanks once again. Thank you very, very much.
Ladies and gentlemen, that brings us to the end of the second Apollo Cancer Conclave, 6th Cancer Conference International on the 8th of February 2015. We hope you would have enjoyed each and every moment of this high-octane academic feast as much as the organizing committee has enjoyed it presenting it to you. On my personal behalf, I'd like to thank Professor Vijayanand Reddy for having invited me and the entire team which has seamlessly worked to make this a grand success. 3 very important women whom I can never forget, who made it possible for me, were Dr. Nandita, my coordinator in Hall A, and Doctors Shilpa and Madhuri in Hall B. Before we depart, as an old saying in the Kathopanishad goes, Shanakshaha Kanashaschaiva Vidya Mardham Cha Sadhyet Ajara Maravad Pragyo Vidya Mardham Cha Chintayet. The translation means every minute in life is to learn. Age is never a constraint, so that we learn, unlearn and learn again. Thank you very much, ladies and gentlemen. Have a safe journey back again, and we hope to look back to see you again in times to come. Thank you very much. Have a great day. Bye-bye. And please join us for lunch.